Hope the lunch was good. Let's reassemble for the post-lunch session. We have some more very interesting discussions coming up. Welcome back to the post-lunch academic session. Our next presentation is by Dr. Akshay Das, Associate Consultant, Critical Care at the Mission Hospital, Durgapur, on to tube or not to tube, rethinking ventilation choices in ED. I would like to request Dr. Shantanu Kumar Das, Director MICU, Dr. Deena Shah, Dr. Shomitra Thandar, Consultant Accident and Emergency, Dr. Nilashri Das, Associate Consultant Critical Care, Dr. Deena Shah, can we please have you on stage? Dr. Nilashri Das, Dr. Tamalika Das, Consultant Anesthesiology, to join this rendition as panelists.
Should you start? Good afternoon to all, and welcome to the today's panel discussion, to tube or not to tube, rethinking ventilation strategies and choices in ED. I welcome all my panelists and the chairperson to this panel discussion. Actually, intubating the trachea, the securing airway is one of the most important procedure in emergency as well as in critical care. Slightly delaying the procedure or too early the procedure can have some devastating complications. Early intubating or whether intubating the patient when intubation is not required, that leads to different nosocomial infection and patient leads to different types of intubation ventilator associated pneumonias and other complications. So we have different cases and where the different clinical dilemmas that whether intubating the patient at the right time or we can delay the procedure. So we'll go to different cases. The first case, it is the first case. Here is a burn patient having 42-year man brought to the emergency with rescue from enclosed wire fire, and patient have 12% total body surface area. Total body surface area, and the patient having some features like singed nasal hair, carbonaceous shoots in the nostril, mild edema in the uvula, but the patient doesn't have any signs of respiratory distress, stridor and all. So initial ABG showed pH of 7.35, PCO2 is normal for within 45 millimeter mercury. Lactates is 4.5 initially due to the disease itself, and carboxy hemoglobin level was 18%. And initially flexible nasal endoscopy was done, that showing mild supraglottic edema. So in this case, and there is dilemma that whether to intubate the patient early or we can wait the patient till the different signs of respiratory distress or edema will develop. So there is always a dilemma in emergency. Many consultants in ER and critical care, they when the patient comes with a facial burn, they'll intubate the patient, suspecting that there will be a delayed presentation, delayed intubation will be difficult. So we intubate early, but many times it is unnecessary intubation is there. So what is, sir, your take, sir, on this? Hey, ma'am, you can also, or what is the take on this? Whether any sign, any score or any...
you were saying that in emergency people intubate unnecessarily?
And in many centers we can see that, not all, everywhere, but many...
Agree with your concern that as a critical care specialist, you don't want people to be intubated unnecessary because it creates a lot of other issues. So to intubate the burn patient, one has to decide from the signs of airway burn.
Yes.
If there are definitive signs of airway burn like singeing hair and how much time he has stayed and how much smoke, was it a smoke inhalation along with or not? Was there any airway, hoarseness of voice and all that? If you find all those signs, then only one should consider intubation. Otherwise, you can wait and do the resuscitation and then decide the plan. That's my take on it.
Okay. Sir, there was one patient in our ICU that has few features like sneezed nasal hair, tongue, leaves was slightly swollen, but no signs of distress. Initially, the respiratory rate was 21. Initially, the patient came from emergency. We are thinking that we should intubate the patient in night, very difficult, maybe land up into edema. But we didn't intubate the patient and observe. Today, in last 2 to 3 days, now the patient is all fine. So, sir, your take whether every sign should be there or some, which are the most important sign to look after for?
Look, this is actually critical to decide because you have to assess how much the smoke inhalation, what is the face burn, or what is the glottic edema and the pharyngeal edema at that point of time. Now, rest of the things are okay. Only thing worry is once you start resuscitation, once you give fluid, it starts swelling. Once the swelling, you can assess for their stridor, because that is the one part we have to take into account. And then early intubation is only for that, for the difficulty of intubation. But for difficult intubation, you have different gadgets to intubate. You can have bronchoscopic intubation, you can have videolaryngoscopy. That is up to you to decide, or the physicians who is looking up to decide. But definitely, early intubation has an advantage, disadvantage as well. Because if you early intubate, the chance of respiratory tract infection happen, all will be there. And patient need ventilation, and all the ventilations consequences you have to face. So it depends on the type of and the amount of edema, basically the pharyngeal edema, and you can time to time assess. Then you can go for early intubation, but not at the site when a patient arrived and intubate. That's what I'm on the for of that.
Mechanism of burn, duration of burn,
Yes.
and the amount of, and the percentage of burn, all will matter,
Okay.
whether to tube or not. So it's not that singeing tha na intubate karo, ye karo, वैसे नहीं कर सकते. You cannot take those decision in silos. You have to put everything together and then take the call, because we are doing preemptive intubation. So you should be able to justify that, oh, this was so much high degree burn, remain in the smoke for so much time. This was the mechanism of injury, and I have to, like, force petrol burn or kerosene burn or those kind of stuff. Okay. Along with the airway burn injury, those patients you have to do preemptive, though they don't have any signs of hoarseness of voice. Hoarseness of voice is the first sign I should not miss. Okay. One should not miss.
So one of the signs is hoarseness of voice.
Yes. Hoarseness of voice and the edema. Particularly if you check time to time, you have to monitor very rigorously. That's what the main point is. The person who is, or the doctor who is monitoring the burn patient, he should monitor rigorously when to intubate. Because too early is a problem, too late is also a problem. But mechanism can be, you can use the advanced instruments to intubate if it is difficulty. Like as I told, bronchoscopic intubation, one of the finest way to intubate. So depend on the person who is, or the doctor who is there, and when the timing also.
Dr. Nilasri, what is if you are suspecting any airway edema, whether we should go for a restrictive fluid strategy or liberal fluid strategy as per the modified, or we should, what is the fluid strategy if we are suspecting any edema?
So currently we are using modified Parklet formula to resuscitate fluids. But again, over-resuscitation is also harmful for the airway, because again, airway edema and glottic edema develop, then we completely lose the airway, and then intubation becomes a catastrophe in ICU, because the type of burn, the extent of burn, if you have a difficult airway, you can neither tube the patient or put a airway, laryngeal mass airway due to restricted mouth opening, and sometimes even the front of neck access airway also becomes very difficult, and we finally lose the patient. So I think we should go, or not judiciously, we should manage the fluid and not over resuscitate. Also, we should try to see some parameters by checking the hematocrit level and the daily blood glasses, which you can see if the hematocrit is increasing, probably the patient is fluid depleted. Then you can see the fluid status. Also, there are various hemodynamic parameters. Also, you can check the IVC status and the other parameters, capillary refill and everything, and you can guide the fluid management in ICU.
Dr. Soumitra, if the patient if the patient having a carbon monoxide poisoning and something, will you go for intubating the patient, or wait? Carbon monoxide is very level is 18%. Will you?
Only for the carbon monoxide poisoning, we will not intubate, because the
level
is only oxygenation therapy.
Okay.
So
we'll give oxygen therapy because 100% oxygen will give. Will replaces the carbon monoxide and. Okay. So. So there is no validated intubation score exist for burn patients, So the different criteria are there, but they are not so specific or sensitive. So it is depend on the clinical status. Judge told by the ma'am that hoarseness of voice, different airway edema sign, that matters more than these criteria. The next case. This is a 38-year man brought to the emergency with speed road accident. Initial GCS was 8, patient was drowsy, and GCS was E2, V2, M4, and breathing spontaneously, intact cough and gag reflex, and CT scan imaging were requested but not yet available. Should you go for, because GCS is 8. GCS is 8, patient is drowsy, it is a high speed road traffic collision. Should you, because as per Brain Trauma Foundation guideline, the patient should be intubated as GCS is 8. Should you intubate the patient or wait and monitor the GCS whether for the action? Dr. Soumitra, what is your take in your ED? Actually, if GCS 8 comes, maybe road traffic accident, maybe a intoxicated patient or alcoholic patient having GCS of 7 or 8. Whether you intubate the patient or wait?
So GCS should not be the sole criteria for intubation.
Okay.
Because we have a better criteria. There is 4 score that includes your brainstem reflexes.
Okay.
That is actually better for assessing overall. Yeah.
Okay.
And also you have to check the overall score. Like motor score is better or verbal score. So that is 4 score, I think, is better for assessing the overall thing. And also what is the aspiration risk, what is the CT room, what is the time needed. If it is more like it is a pan CT scan, that is for
transport.
trauma.
You are telling transport
time
okay.
more. So that is maybe a criteria that like more time needed for CT scan, outside ED I mean. So that thing GCS 8 can be considered because we cannot monitor in the CT room.
Okay. Okay. Dr. Nilasri, what is your take on this? Whether intubate or bigger different guideline telling to intubate at GCS of 8. But many patients having GCS of is a combination of E2, EVM. So some patient having M5, E1, V2. The AM have a different. Okay. 4 score. But ma'am, in GCS is mostly used for brain injury patient, mostly accidents. But in patient having any septic encephalopathy or any uremic encephalopathy or any patients with intoxication patient, should you use GCS as a sole or 4? 4 score actually we should use, but we are not generally used. We are using GCS only GCS. 4 score actually it is okay. Second patient, okay. Okay. Okay.
From mechanism to presentation to your assessment. Everything to be combined, and then only you cannot say ECS. This is just a comparative score where
Okay.
you can assess the patient ongoing. It is not to be used for taking the procedural decision. That's what it is.
Okay, ma'am.
Same way, the airway burn cannot be used as using say airway burn and I have to intubate. You cannot say that. You have to look at it from mechanism to the how much it is burned and what is the resuscitation required, everything. Then only you can take the call. So any one criteria, sign, be it a airway signs or GCS, cannot be used to decide I want to intubate. That's my stake.
So clinical judgment.
Answer in
Okay.
nutshell instead of going over.
Okay. Clinical judgment.
Of course.
Overall, the patient from head to toe, all the parameters.
Mechanism.
Mechanism of or further deterioration chances.
Yes.
that might be.
Yes.
Also, I want to say that these traumatic brain injury patients have a high risk of developing secondary brain injury.
Okay.
So, you know, I have to see all the parameters: hypoxia, hypercarbia, any seizure, fever, normoglycemia. So all these parameters, there is raised ICP. So all these, if you are suspecting that any of the parameters are alarming, then go for intubation. There is no harm in intubating the patient. But delaying the intubation increases the mortality. So I
If,
think...
if a patient is planned for surgery, we are keeping, try to keep the CO2 of 25
Yeah,
to
if
30.
the patient is maintaining all the parameters, you are monitoring in ICU on time to time basis, then it's okay. But if there is any single red flag, then go for intubation, because this I've seen all the patients that with a poor GCS, sooner or later they tend to aspirate. So it's better to protect the airway. Later, as the GCS improves, you can try on extubating or do a early tracheostomy, whatever the patient's neurological status is.
Okay. Sir,
The
what?
single most risk is the aspiration.
Okay.
A patient of trauma and a brain injury likely to aspirate. That aspiration you have to prevent by taking care control of the airway, right? Number two, if the patient is in hypercarbia, see carbon dioxide is increasing, the oxygen is falling, PO2 is falling, then I think better to take a control of airway early. Because if patient gets better, so within 6 hours, 10 hours, 12 hours, you can extubate out. If you, time to time ABG, as you're doing ABG, electrolytes and all parameters, particularly acidosis. Acidosis part, if patient is having acidotic breathing, you cannot control by giving simple oxygen. So then you have to take many things into account: acidosis, carbon dioxide, PO2, potentiality of the aspiration. That is the biggest problem in India. Is most of the doctors, whether in ward, emergency or in ICU, they don't put into the knowledge that this patient vulnerable patients can aspirate. Once aspirate, it's the biggest massive catastrophe for the patient. So accordingly, multiple criteria, monitoring and taking control of airway. That could be the best thing I can say.
So the aspiration risk, the need for surgery, the how prevention of secondary brain injury to prevent hypoxia, hypercarbia, acidosis, hypertension, and if needed, if they raise ICP, we have to keep CO2 in a particular range. So all these factors we have to take into consideration before going for intubation. So
Another thing which is transport. If you are transporting the patient, I think somebody of us has told, transporting a patient, secure airway and transport.
Okay.
Depends on where how far you transfer.
No, if you shift to OT also, if patient is potentially, you cannot just shift with the oxygen, right?
No,
During this, during this transport, patient can have cardiac arrest, suppose he is in acidosis, in hypoxia or something else. And it is better to intubate, take the safe steps and transport the patient to OT, let them do a surgery, come down to ICU, they can extubate.
If the patient is planned for surgery, we are shifting the patient to OT, so we can intubate and
Depending on the situation. I mean, what I say, if the physical injury, the other parameters are deteriorating in acidosis, in spite of fluid resuscitation, whatever blood you give, if the patients are delayed for say 1, 2, 3 hours because you OT, till the OT is prepared, so then you have to take a chance or take a decision on that.
Okay, sir. So we have already discussed all these things. So this is the third case. This is a 65-year-old man presented to the emergency with a history of 5 days fever, cough, progressive shortness of breath. Patient is alert, conscious, speaking in short sentences. GCS is full. Complaint of fever, cough, progressive shortness of breath. Heart rate is 112. Respiratory rate 34 per minute. Blood pressure normal limit. He is maintaining saturation of 86% on room air. And when the patient is putting on non-rebreathing mask, he is maintaining 94% on 15 liter of oxygen. And this is the chest X-ray picture, radiograph, and this is the ABG. PO2 with NRBM mask, the FI2, suppose the FI2 PO2 ratio here, PO2 FI2 ratio is 180. So patient is tachypneic and ABG, lactate is also around 4 or 5. So should you go for intubation or only keeping the patient on NRBM mask or HFNC or NIV? So ma'am, what is the first in your...
I would like to ask the people on the crowd because it feels we are only discussing and you are all busy with your phone. So can I have the hands up who wants to intubate this patient? Hands up. Only one. Anybody else? Okay, who don't want to intubate the patient? Only 4, 5. What about the rest? Huh? So this discussion is for the people who has not raised their hand on either side. Okay? So Dr. Tosi, yes ma'am. Yeah, it's not a discussion for emergency. It's not for the emergency. It's for anywhere. It doesn't say that patient is in emergency and whether you intubate or not. You might come across the patient like this in an ICU round. What will you do at that point of time? That's the question can be, right? Somebody has put in the previous shift, the patient on NIV mask, you are coming, these are the criteria. What call you will take? You can answer now? It's just a matter of discussion because at point I feel like I'm giving exams. Yes, ma'am. What's your opinion as a critical care? Because he is asking from critical care perspective only. मैम अभी आपने बोला आप क्रिटिकल केयर हो तो मैंने बोल दिया
Transfusion medicine. She is actually in the transfusion medicine.
but they work in ICU.
No, they don't work in ICU. They are purely dedicated to...
Okay, so some confusion on my side, I apologize. Anybody else?
There are many ICU RMOs here. Anyone can
I think
volunteer
Dr.
to
Tosif
answer.
only wanted to intubate, so
Intubate only.
he can justify a rest, don't want to
Why
intubate.
you intubate early?
What about you? You want to intubate this guy or
No,
not?
I will not going to intubate.
Okay, then let's hear from Tosif.
What is your sir take on...
One against all.
You can give some microphone to...
Of course, yeah, to shake the boat.
Thanks. So like I said, I was just playing the devil's advocate and trying to create an alternate point of view. The only criteria amongst all of this is like a visibly stable patient, right? You're thinking at the 86% saturation, you should be able to manage with an NIV, max case NHFNC. My problem statement is the PaO2 FiO2 ratio. It is 180. Acute lung injury going towards ARDS, is it better to intubate early or late is a decision, a tricky decision that we'll have to make. So I don't think either choice is bad. If you are going to intubate, you might as well be, you should be knowledgeable about ARDS ventilation. How will you ventilate an ARDS patient, which is a high rate, low volume ventilation and permissive hypercapnia? If you know that, you can intubate. If you don't, then you might want to follow NIV and HFNC and so on. Yeah.
Is it justified for you?
Because intubate...
I would like to add one thing before I take the
Yes,
call.
sir.
I want you to answer first.
I will not going to intubate the patient first. I will put the patient on HFNC and wait, and then I will go for intubation.
I would, if this patient's past history or previous history is available, I would like to know. Because if he is a CO2 retainer in his past...
No, sir. No, not a.
We have not mentioned here.
Not a COPD patient.
Not mentioned here. That's why I would like to know before I intubate this guy.
Yes, ma'am.
Because right now his CO2 is sitting somewhere, okay, and the PO2 ratio is compromising. But if he is at the age of 65, if he is a COPD, I would not like to intubate. I would like to maintain him as it is and see how he goes. If he deteriorates or collects the lactate because of his sepsis, then he can be intubated. And as he has added earlier, if this patient needs a transfer out, yeah, it depends on how long he's going, you can consider intubation as a prophylactic. and inform the receiving hospital that this is the only reason we have intubated. And he should not have COPD retainer history, or he should not be the smoker. It is not mentioned here.
He actually not mentioned that he is not.
Yeah, that's why it needs to be cleared.
Yes.
Exactly.
He's not.
This is a scenario where it is a hypoxic. Basically, ARDS, the picture is ARDS. Now, in ARDS, when you get a patient of, say, FIR to PIR to ratio is less than 200 or something like that, if patient rate is less than 30 or around 30, and patient is maintaining decent saturation, like say around 90, 92, you can go for conscious proning, number one. Number two, you can go for the NIV, if she or he tolerates. You can think of delaying, because once you intubate in ARDS patient, the complication, the intrications of ventilation is not that easy. Because we know, we ventilate. Recently, we took out a ARDS patient after 80 days. She was on the ventilator for 70 days on the ventilator, including trachea. So there will be a lot of long injury. Even if you ventilate very nicely, there will be villi, there will be barotrauma, there will be volutrauma. So what we do in our ICU, when the patient is holding, right now one patient is there, we have intubated and proned for 3 days, then we did conscious proning. She is right now actually recovered back. So conscious proning is a very good tool with NIV or HFNC, but you have to monitor the PO2, because the oxygenation part you have to take care of the secondary injury to the other organs, and treatment of the primary cause or source control. If that is earliest, so patient will recover early. So intubating, non-intubating depends on the patient criteria, as Madam told. If it is a carbon dioxide retention, if you know it is a COPD patient, obviously you have to look into the carbon dioxide. Even if in ventilation also, we look into carbon dioxide, because in few cases, I think John knows, he is regularly visiting to India, to our hospital. We used to use permissible hypercapnia in case of ventilation. Suppose the PCO2 is 60, but the PO2 is 50. You cannot push the entire tidal volume and give high PEEP. He cannot tolerate, he'll end in pneumothorax, he'll end in lung injury. Okay. So, before intubating, you should try other methods if it can possible. If not, then you can go for intubation and ventilation. That's what my take is.
And lastly, whether if the patient has not ARDS, only a lower pneumonia, whether your decision will change or will pneumonia, by one single lung lower pneumonia.
You can daily check the blood gases. If the patient, again, on NIV and HFNC, there are various scores to see whether your patient is tolerating the equipment or not. There are ROC score for HFNC and Hacker score for NIV, which we do regularly in ICU. If the patient is not tachypneic, basically the patient is not tachypneic, is comfortable on NIV or HFNC, not requiring too high flows, because too much high flows and too rapid breathing there is something called as patient self-inflicted lung injury, PCL, which can develop on, there are patients on NIV who are taking large tidal volumes, and you're seeing the patient is actually failing the NIV. That is the point where you need to intervene and do intubation. Okay.
Intubating the patient with a NIV failure is more hazardous than intubating early.
So again, but then you have to be aware of the proper ventilation strategies in ARDS.
Okay.
And
so this is the ROX index.
So in this case, I think the patient is in moderate ARDS.
Yes, moderate.
So it is shown in the studies, previous studies, that mild ARDS, HFNC has better result. It actually decreases the mortality. But moderate to severe ARDS, it actually increases the mortality. So I think in this case...
If the patient is having COVID, then?
Sorry?
If the patient having COVID-19 or SARS-CoV-2, whether your decision of intubating the patient or put on the...
COVID, HFNC has a good result rather than the non-COVID ARDS.
So depend on the etiology, your decision will change?
Yes, obviously.
And if the patient having some comorbidity, that will also change your decision. Whether the patient having any other patient having a cancer anywhere, and patient having metastasis, now patient with
Yeah,
immunocompromised
obviously,
state.
there is a palliative intent for treatment, so we
So
discuss
patient
with family.
condition, patient
Yeah.
status, all matters when we're intubating.
In non-invasive, you have to see the fatigability, the pump failure. Fatigability is one of the things when you are trying something before intubation.
Yes. Now, it is a simple case. It is a 68-year man with a COPD. 5 minutes. COPD present with increased cough and patient having a pH of 7.25, CO2 78, PO2 of 58 and respiratory rate 32, heart rate 112. SpO2 86, room air 92 with Venturi mask of 28%. So, it is whether go for intubation or put on the patient on NIV. It is a similar case like the previous. So,
We already discussed
yes, it is the NIV.
Points.
Yes.
No, this is the key point in COPD is the best is NIV. The best. Suppose it fails, what to do? You don't have your lung function in your hand. Suppose a patient having severe COPD with a very poor lung function. If you are intubating, the outcome is very poor. First time intubation, literature writes, first time intubation in COPD, the chance of coming out is bit fair, but you never know. So NIB is the best, but intubating a patient means you are having as a difficult customer in ventilation.
Dr. Soumitra, I will ask, we have put the patient on NIV. Initially, pH is 7.25 and then we did one ABG after 1 hour and there is some amount of leak around the NIV and the pH went down to 7.15, carbon dioxide slightly increased from say 78 to 82, but patient is conscious oriented. Should you intubate the patient or wait for check, we'll adjust the NIV or EA, wait or we'll intubate the patient because pH is 7.15.
So, as you mentioned, there is mask leak, so we'll give a more trial proper seal and also assess the sensorium or see for other contraindication for NIV. If patient can tolerate, I think we'll give trial for.
So another 1 hour, then.
And we assess, as Dr. Nilasri mentioned, hacker
So
score.
whether pH is a criteria for intubation in COPD?
There is nothing.
Patient probably deteriorated, you have to check your parameters of resuscitation.
Yes.
Whether your antibiotic has gone, whether your fluids are on, because those can make him deteriorate as well.
Yes, yes.
So that is why don't rush in with intubation, as he is saying correctly. Before intubation, you have to ensure you have exhausted all the possible things you can do for him. Then only go for intubation in such patients.
Okay, ma'am.
Right?
Yeah. There is one point. Managing a COPD patient is an art, I will say. It's an art. Because as long as patient is conscious, taking breath, and his work of breathing is reasonably good. Work of breathing. I mean to say work of breathing. I will not look into the PCO2. If patient is alert, conscious, I can try him or her as long as possible. Because I know once they land up in ventilator, they are a difficult customer. You cannot take them out. Yes, tracheostomy and all, they'll continue to be in the ventilator, and that is called dependency. They depend on the ventilator. So always, as long as there is a carbon dioxide, people live with 80 carbon dioxide, they are conscious, alert, talking, taking food, and keeping out mask on and off, NIV mask. So depend on the patients, tailoring your treatment to the every patient. And one thing you should have in mind, if you have got a lung function previously, COPD patients have all PFT they have done. You can ask them to bring the PFT. You can look into the PFT. If it is severe, don't intubate. Don't intubate.
So, I will complete. The last case, within 1 minute, it is every day we are seeing in emergency sepsis patient on dual vasopressors, pH 7.2 and lactate is 13, respiratory rate is because bicarb is around 11, 12, lactate is 13, patient hyperventilating to compensate. Would you intubate or you will continue the vasopressors or put the patient on NIV or HFNC or something, or what you will do? In this patient, every day we are seeing this patient, and sometimes we are shift the patient to, there is controversy whether to intubate now, because intubating the patient in this condition, because it is a physiological difficult airway, because intubating at 7.2 pH and giving some sedation will further land him compromise. So whether intubate or not to intubate.
Intubate, but do the resuscitation.
Resuscitation first.
Because if you intubate in this condition, as you correctly mentioned, any amount of sedation will drop the blood pressure and you end up CPRing those people. So septicemia is very tricky. You have to be ready with everything for intubation, but you try and give the fluid boluses and all. By the time you prepare, your team prepare for the intubation. That's how I look at it for this patient.
For septic patients, acidosis is a challenge. So as long as they're acidotic, you have to deliver oxygen in proper way, whether you give in mask or rebreathing or NIV, because delivering oxygen can modify the acidosis beyond the primary cause. Second, they are in cytokine storm. So resuscitation and resuscitation the first goal. Second is, if the acidosis is not getting corrected, you have to deliver oxygen, because in acidotic medium, the download of oxygen is always difficult in case of septic patients. So ideally delivering oxygen is a good way. Whether you choose for intubation or some other method, it's up to you depending the situation. But always early intubation in a high hemodynamically unstable patient is definitely gives a far better result, I believe.
Because when these patients, generally what happens in emergency, after you do the initial resuscitation, these patients are transported to the ICU. In ICU, we often find these patients, when they arrive, they are already in gasping condition. So, there is a development, what happens in shock, there is development of type 4 respiratory failure, where there is decreased perfusion to the respiratory muscles, leading to respiratory muscle fatigue. And these patients, due to that issue, often develops respiratory arrest. More than cardiac arrest, they develop respiratory arrest. So I think if your resuscitation is going on, it's well and fine, patients' lactates are decreasing, ABGs are improving, then you can continue with your supportive measures. But if you see after arrival, if you take an ABG, with ABG is worsening, your lactates are rising to 20, 25, or severe metabolic acidosis, then go for intubation.
So, Dr. Soumitra, every day you are seeing this type of patient.
So I think this is the typical patient for a peri-intubation cardiac arrest. Patient is acidotic, not maintaining hypotension. So before going into intubation, we have to stabilize the patient as far as possible. We have to give fluid boluses, start vasopressors, and one thing that keeps the BP is the patient's sympathetic support. When you're giving sedation, that sympathetic support is gone. So during intubation, we have to give adrenaline. That is, we use push dose vasopressor.
Push dose of vasopressor during intubation.
I think that is a must, and also give a extra oxygen support during intubation through nasal cannula. I think it is come into the difficult airway algorithm in 2025. You have to use in difficult intubation additional oxygen source also.
Thank
So we can have the answer once from the audience. Who wants to resuscitate first and then intubate? And who wants to intubate now? So you have put the message across the crowd?
And everyone is actually, the patient having BP of 70/40, no one going to intubate. First we'll increase the vasopressor and something, then intubate. Because when we'll give the patient suxamethonium or because patient is respiratory rate is 32. Now that's why the pH is maintaining 7.2. Now when we'll give sedation, the pH drop down to 6.9 and patient suddenly arrest. And additional dose of suxamethonium also there or anything. So ventilating during the time of intubation also important, because RSI sometimes we're keeping the patient apnea. That may be detrimental, because because patient respiratory rate was initially 34. Now we have keep it at 0.
The sympathetic stimulation is gone after.
Sympathetic stimulation is also gone. So different strategies we'll apply. So.
Other point I would like to mention what her concern was that sometimes we rush the patient from one area to another area, instead of completing the resuscitation.
Yes.
That should not be done, never to be done. Once you receive the patient, keep him in the same area, get whosoever help you want. Never ever transfer the patient from A to B, because that's criminal to have patient coding en route to ICU.
Okay.
So never rush to the ICU because you don't have anybody who can intubate in emergency room or whatever is your limitation. Call the ICU downstairs and do the resuscitation, stabilize then only. So they don't code in your own hospital en route.
Thank you, ma'am. So thank you all my panelists and my chairperson, ma'am. So this is a very nice discussion. We have discussed 5 cases. So there are some controversies and some common consensus. So it is very nice panel discussion. Thank you, ma'am.
Thank you very much.
Thank you.
Thank you so much, moderator and panelists. May I please request Dr. Dina Shah to give away the mementos to our moderator and our panelists. All 4 of them. Dr. S.K. Das, sir. Dr. Nilashri Das. Dr. Shomitra Thandar. And our moderator, Dr. Akshay Das. Thank you so much, ma'am. We are elated to have amongst us today Dr. Sanyukta Datta, Emergency Department, Fortis Hospital, Kolkata, to enlighten us on diagnostic excellence in the emergency department, clinical reasoning in time, critical emergencies. Ma'am.
Good afternoon, everybody. I am sure the post-lunch session, everybody is sleepy. Can I request you to stand up once for me, please? Please stretch a bit and sit. Thank you so much. See, here I am not here to just speak and go. I want you all to speak as well. Okay? Thank you. So today we are going to talk on the diagnostic excellence in emergency. How many of you were in emergency? Can you please raise your hands? And how many are from medicine, ICU? Okay, so this is the emergency medicine lecture, but I believe if you are a doctor and dealing with patients, especially undiagnosed patient, you will be able to relate. So in emergency, the paradox is the emergency physicians are expected, can you switch this off? they're expected to make high-stake decisions, but within a very short time, the patient comes in, the patient relatives ask, what happened, doctor? When he can go home? Will he be cured? Your customer care asks you, which bed I should book? Which specialty this patient will go? So you are going to answer all these questions. So basically, this is something I love about emergency. I love this challenge. I love this adrenaline rush. Here in emergency, you are not expected to do the art of making perfect diagnosis within seconds. But you are here, the emergency medicine is the science of making safe decisions in the face of uncertainty within a very short time. Can you take this red one off? Why it is coming, the red one? Yeah, thanks. So today this is not a lecture on disease. This is not a lecture on investigation. Here I am going to discuss how expert emergency physicians should think. Technology has evolved a lot. We were talking about AIs. But human thinking is not evolving, rather it is going backwards. People are into reels, people are into social media, they are not thinking. So we need to learn how to think as a good physician. When you are taking high-stake decisions in no time, you will have to have the power of thinking. So here I am going to talk on this. In my department, I tell all my students, all the junior doctors, please learn how to talk to the patients because they do not read the textbooks when they come to you, do they? At times, my junior doctor tells me, and he gets furious to the about the patient. He didn't tell me this history. When you asked, he told, but before when I asked him, he didn't tell this. So what the problem is? You are taught how to take the history. The patients were never taught how to give history. So the responsibility is all yours. And please remember, the patients present with symptoms and not the diagnosis. The symptoms at the beginning and the road you are taking will lead you to the diagnosis. So my doctors are not allowed to write fever, syncope, jaundice, these kind of chest pain. You cannot write these as diagnosis. You try to evaluate and write the proper diagnosis. If you cannot reach in that time, you can write under evaluation. But those are definitely not diagnosis. Those are symptoms. So our job is re-stratification, not instant diagnosis. So definitely you can write under evaluation, but that is not the end of evaluation. This is a quote from Sir William Osler. Listen to the patient. He is telling me the diagnosis. Actually, he is. Maybe not in the order you are expecting. Let us discuss about a patient. It's a 52-year-old diabetic man with pain abdomen, vomiting, no fever, diarrhea, tenderness, vitals, pulse 110, BP 116/70, temperature normal, saturation 100%. What will you do? What will you do? People from the back. Say something, I told you, otherwise I will not talk. Sorry? Okay, then? Let's continue. See, in emergency, we always talk about A, B, C, D. Yes, we will do that. But here, while you are thinking, please remember a couple of rules I am giving you. So rule number 1, red flags override your probabilities. Think the worst first. Ask 3 questions. What can kill the patient? What cannot wait? And what diagnosis would I regret missing? So if the patient comes with chest pain, think immediately about the life-threatening conditions. It could be ACS, it could be aortic dissection, it could be PE, it could be tension pneumothorax, esophageal rupture. If the patient comes with headache, please remember subarachnoid hemorrhage, cerebral venous sinus thrombosis. cervical artery dissection, meningitis, encephalitis. Same for breathlessness. Think about PE, heart failure, pulmonary edema, tension pneumothorax, status asthmaticus, and so on. Abdominal pain, think of mesenteric ischemia, ruptured abdominal aortic aneurysm, perforated peptic ulcer, ectopic pregnancy. Then if the patient comes with syncope, think of arrhythmia, heart block, brady or tachyarrhythmia rather, structural heart disease, PE, and so on. This is just an example. It is not all including everything. So this is an idea that whenever you hear a symptom, definitely the common things will come to your mind first. But remember, try to remember the life-threatening conditions and think if the patient is having that or not. Rule number 2, why physicians misdiagnose? Is it the lack of knowledge? Yes, at times. But there is an interesting study by Pat Proskauer. He said most diagnostic errors are not due to lack of medical knowledge, but failure of clinical reasoning. So we will discuss about 2 thinking errors. One, pattern recognition versus analytical reasoning. Next, we will discuss a couple of cognitive biases. Now, pattern recognition and analytical thinking. Analytical reasoning, that is your system 1 thinking and system 2 thinking. Suppose a patient comes in, known CKD patient on hemodialysis. He has come with severe shortness of breath. What will you think first? Your first thought. Again, silence. CKD patient on dialysis comes to you with severe shortness of breath. What do you think? Yes, we think of pulmonary edema. Someone has, allergic to prawns, had prawn, has now come with low blood pressure, shortness of breath. What do you think? Anaphylaxis. A 22-year-old female has coming to you with very fast breathing. What do you think? Immediately hyperventilation. So these are actually your pattern recognition. Is it bad? Good and bad. Basically, you need to know how to recognize patterns, because in busy emergency, that's a big weapon for you. So you recognize patterns quickly. So you diagnose quickly. But then it cannot end there. So after you recognize the pattern, you need to ask yourself if everything fits. Then comes your analytical reasoning. If the patient is coming with shortness of breath, a young female, then you take the other history and try to fit everything. Analytical reasoning is you think deeply, you take more history, you try to fit in the diagnosis with what you were thinking. If it doesn't fit, you go deeper. So question and reassess. Experience teaches us how to recognize patterns and diagnose quickly. Wisdom teaches us how to question them and go deeper and refine our diagnosis, reassess and reconfirm. So that is about pattern recognition and analytical reasoning. Both are required because one gives you a quick win and the other gives you the perfect diagnosis. So you need a mix of both actually. Next come cognitive biases. These are systemic errors of thinking that influences our clinical decisions. What could it be? First example, the same. The patient comes in, a young female, 16-year, 20-year, comes with very fast breathing. Immediately you think of panic attack. So what is this called, you know? This is called anchoring bias. What is that? Becoming fixated on a first diagnosis and failing to adjust despite the new informations. Yes, you can think of this, but then you need to go deeper and try to understand if there is anything wrong. A patient comes in with abdominal pain. You did an ultrasonography, you got a gallstone. What do now? You admit the patient on general surgery, shift them to ward. But it could be that the gallstone was there. This time he has come with gallstone pancreatitis, or maybe the gallstone is incidental finding, the patient has come with MI. So this is actually premature closure. You are getting one plausible diagnosis and stopping your thinking. This is premature closure. Remember this, don't do it. 55-year female comes with shortness of breath. You think this is LRTI, you ask about fever, cough, everything is there. Inhalers, yes, the patient is a COPD patient on inhalers. Then your senior comes, goes deeper and asks, have you checked the temperature? What was it? He says it was a feverish sensation, but temperature was 97. Was it fever? Oh, you had cough. Yeah, I'm a COPD patient. I cough all the time. Then you take the history and the patient had recent PTCA. The patient looked pale, had black stool for the last couple of days. So ultimately it was GI bleed. This is a recent patient I got in my department. This is confirmation bias. You are seeking evidence in your mind that supports your diagnosis while ignoring evidence against it. So we all can have these biases. If we know, it would be very easier to avoid them. After 5 dengue patients you have seen in your department, a 21-year male has come with fever, chills, headache, body ache, vomiting, rashes, low blood pressure for a day. You diagnose it at what? Dengue. You miss meningococcal sepsis. So this is availability bias. What is it? A recent or memorable cases disproportionately influence your thinking. What you missed? Can you tell me what you missed here? Anybody? No, rash. Both of them can get rash. Low blood pressure in a day. The dengue patient will not deteriorate in a day. They can deteriorate, but that will take a couple of days. So that's the clue you missed. So here you need to be vigilant, you need to be thinking very fast and deep. Next, diagnostic momentum. We see that all the time. Once a diagnosis is attached to a patient, everyone accepts it. Referral note says seizure on Levipil. ED writes seizure, ICU seizure, neurology seizure, eventually intermittent CHB. Nobody bothered to see why this patient was put on Levipil. Was it a proper seizure or stroke Adams? So somebody needs to stop and say, what if it was wrong? Do not inherit diagnosis. Reassess it. In my department, I tell my residents, do not see the referral paper. Do not see the outside prescription. See the patient first. You decide on yours and then you see those papers. First, you use your own brain. Come back to our patient. The patient's USG was done. Multiple gallstones were found. PPI, antiemetic, antispasmodic was given IV. Next rule. Be aware of normal vitals or investigations. They might be misleading. Normal ECG cannot rule out ACS. Normal troponin, can it be no MI? If you do it within 1 hour, it could be negative. Normal CT brain, no SH, no. Normal chest X-ray, no PE, normal temperature, no sepsis, normal blood pressure, no stroke. All these are not true. So bottom line, never let a normal test overdo an abnormal patient. Investigations reduce uncertainty, but they rarely eliminate it. Rule number 4, I will give 7 rules, that's it. So rule number 4, treat physiology before everything. So I always tell, and I am telling you, learn the pathophysiology. If you know what is going wrong inside, it would be just not easier to treat, but interesting to treat. You will find the joy in treating a patient, diagnosing a patient. So what is going wrong, you treat them. Because patients do not die because you haven't named the disease. but they die because maybe your physiology was failing and you failed to address it. Stabilize first, diagnose as you resuscitate. It could be like you check A, B, C, D, E that way. If it's a patient of shock, you think of pump, tank, pipes, oxygen delivery, and assess and treat. Then, rule number 5, chase probability, not certainty. Nobody is telling you and asking you to give the diagnosis in 2 minutes. So this is Bayesian thinking. What is it? It is a moving probability. So diagnosis is not a moment, it is a moving probability. What do you mean? You get the patient. I tell it this way. You get a patient. You just think this is a puzzle because it is an undifferentiated, undiagnosed patient. Treat it as a puzzle. You take the history, you get a clue. You examine the patient, you get another clue. You narrow down your differentials. You think what could be the patient's probability of the disease and then narrow down. You reassess and reconfirm and then you reach towards the diagnosis. Because medicine is rarely 100%. You work on the probabilities. Rule number 6, use focus. It's very important and useful tool. It can change the probability. Can you give the diagnosis? Can you tell like, yeah, this is patient is suffering from this disease? No. But you need to ask question and it can give you answer. You ask if there is tamponade, yes or no. IVC is collapsed or dilated. The patient has got pneumothorax, yes or no. Free fluids in the abdomen, yes or no. You can immediately get those answers and you can actually narrow down your probabilities and reach towards the diagnosis. Again, our patient, you have done the focus. IVC is collapsed. What do you think? Anything comes in mind? Okay, so IVC is collapsed. As we said, the patient may be in shock with a normal blood pressure. Here, blood pressure is on lower side. You ask the patient relative. At home, the blood pressure is around 150, 160 systolic all the time. So here, the IVC is collapsed. BP is far below normal, his baseline. So the patient could be in shock, right? Yes or no? You check the ECG, there is no ischemic change. Drop negative, lactate 5. Okay. The last and 7th rule, diagnostic timeouts. Before admission or discharge, ask yourself, does anything not fit? What else could this be? If I am wrong, what diagnosis would harm the patient the most? This simple pause reduces errors, and that is very important. Am I actually? Is it? No, I didn't notice actually. Okay. So here, again, the patient. What doesn't fit? I have made them bold. No tenderness. Pain is not subsiding. You have done the focus. IVC is collapsed. You have checked there is no ischemic change. But the ECG shows rate-controlled AF. Lactate is 5. This is a real patient. We got this patient and spent some time on this patient. So eventually this is mesenteric ischemia. So this is a killer condition. We cannot miss it. So take home message, symptoms are not diagnosis. You need to reach the diagnosis. Recognize patterns, but questions them when it doesn't fit. Treat physiology first. Normal tests never overrule an abnormal patient. Ask yourself, what am I missing? Slow your thinking before disposition. Reassess, reconsider, and then decide. All the best. Trust your training, believe in your thinking, Be kind, keep learning, keep going. Thank you so much.
Thank you so much, Dr. Sanyukta Datta, for such an enlightening session. May I please have Dr. Auditro Rai, Assistant Medical Superintendent, to come on stage to give away the memento to Dr. Sanyukta. Thank you so much, Dr. Datta. Thank you so much, Dr. Auditro. Please join your hands to welcome Dr. Taroknath Tarobdar, Deputy Medical Superintendent, the Mission Hospital, who is going to engage us with his topic, From Door to Disposition, How Integrated Emergency Care System Improve Safety, Quality, and Outcomes. He would be joined by Dr. Debashish Dasathikari, Dr. Devkant Pradhan, Sister Saraswati Roy, Dr. Auditro Rai, Dr. John Acera, okay, and Ishani Chakraborty.
Good afternoon. I think after the enlightening talk by Dr. Sanyukta, everyone is wide awake. This is again about the systems. And an integrated emergency care, usually a care from the community through the emergency into the hospital, integrating all aspects. But today we'll focus more on the inter-hospital communications and integrations. So actually, these are the links in the community. Then there is the EMS, and the focus will be on the time-sensitive medical care to give a good outcome. Now, the core of integration is an effective communication. I think everybody will agree. And the key components of these 4 key components will be focusing more on the structured triage and continuity of care. As per the WHO, they have proposed for better outcomes. One of the things, they call it ECO, Emergency Critical Care and Operation Theatre. And there is the integration that will lead to better outcome. Prevent deaths, reduce acute illness and complications. So in our discussions, we'll be focusing quality. There are many definitions of quality. We'll be focusing mainly on the compliance to the standards or the clinical protocols, and the safety will be playing with the IPSG and the WHO patient safety solutions, of which 5 out of the 9 safety solutions are based with, related to medication safety. So we'll have a bit emphasis on this medication safety, especially in the ED and in a challenging situation of a surge, which we often see in the EDs. The challenge of the resource limitation, and this is the answer that WHO gives us. That is system planning, which Dr. Paul had told in his opening comments. So we'll be going to, I'm not going to those theories, we'll be following a patient throughout the journey from the community to the ED. But before coming to that, first, again, I'll emphasize on the communication. So may I come to Dr. Dasadhikari, sir? Can you elaborate something on the need of communication between all these EMS, emergency doctors, and all other partners and stakeholders?
Actually, I think the EMS is not well developed still in India, and whatever is there, that is in a private sector. And government sector EMS, I have not seen much. Though I am working in CMC, I have not seen much. But it's definitely much better than before. And EMS handovers, I am not very sure it's existing or is happening. I am not very sure.
Sir, within the emergency and within the hospital intradepartmental emergency communication with the, say, cath lab, ICU, imaging, all these things?
See, emergencies is against the time. And what was discussed in the morning, the codes, that those code itself has a well communication among your entire hospitals. So if you have existing code systems, and where is the time is the muscles, time is the kidney, time is the brain, very much essential because every second counts. So I think like your hospital where you have developed established code systems, that itself is indicator of a communication, good communication.
Yes, sir. So I think that is a very clear message to all. If we stress on the codes, that will give a very clear line of communication among all the departments. May I come to Madam Ishani Chakravarti? Madam, what about communication with the patients? They are often very dissatisfied, as Dr. Sanjukta was telling. They are not coming with the reading the textbooks. So what are the expectations of the patients, that how should we communicate as a healthcare worker or emergency doctor, emergency nurse, who themselves are under constant stress?
The patients, we must remember, they come with a lot of anxiety. They want somebody to listen to them. They want somebody to pay attention to them. Then they feel that they are attended. So in an OPD scenario, they want the doctors to listen to them before starting to write the diagnostic tests and the medications. In an emergency scenario, they want somebody to listen. The doctors know what they're doing. When a patient is coming, a trauma patient is coming, they're put into a triage and the doctors rush there and they start doing what they're supposed to do, the initial assessments and the diagnostics. But the patient relatives who are absolutely conscious, they are lost. And they are the ones who create those impressions and the satisfactions or the dissatisfactions at a later stage. So somebody from the system, maybe a non-clinical staff, a coordinator in the ER, or a nursing staff will have to go speak to them, pacify them, tell them that we are attending, we know what we are doing, you please stand by. You know, you can stand there, we will draw the curtain, we will do what we will have to do, we know what we are doing, so you please just wait for a while. Then after attending to the patient, the doctor will come back to you to tell you what they are doing. I think this communication is very important to give them confidence.
I think the message is very clear. Empathy and patient-centeredness. This is what often we miss when we are treating patients. We jump upon the patients, but do not think what the relatives are thinking. They are anxious too. Now coming to our direct intervention with the patients. Triaging. May I come to Dr. Aritro? What are the risks of errors in triaging? Will there be any harm if we under-triage?
As earlier discussed, with the seriousness of the patients and their relatives regarding their patient condition. They have the anxiousness among them. Triaging in our emergency is a very difficult proposition or very difficult scenario, because in our scenario, most of the patients, they don't love to wait. They just want a bed and want to be examined by a doctor. This is the place where we are lacking the most, because in an acute care scenario, high acuity patients, they get missed up. Because a normal looking OBS patient should be considered, should be triaged high. But in our scenario, we examine them slightly late. We don't give due importance because they are not triaged properly. So triaging as per our protocols, our standard guidelines is very important, so as to segregate the patient and have a proper disposition.
So, hello. So triaging is the backbone and the cornerstone of any good emergency department. And you know that there will be urgent, like priority 1, priority 2, and priority 3. Priority 1 means they are fighting for their life and has to be seen immediately. Priority 2 means they can wait for some time, but they can worse any time. And priority 3, they are not sick. They have preferred to come to emergency. You cannot send them also, because all private hospitals, they don't like to send any patient. So you have to have a dedicated system to attend all the 3. And so you cannot be rude to the non-sick patients. You cannot take time to attend the urgent patients. And also, suppose somebody, you say you wait for half an hour, suddenly he worst, he'll take a mobile phone and put it in Facebook and say, live streaming will be going on for whole countries. So we are in big trouble. So you must have a system, must have a robust triage systems. It has to be validated, and senior most nurses, paramedics, and doctors has to be dedicated team. There has to be a team in emergency department which consists of nurse, paramedics, and doctors, who is the backbone of your emergency department. You cannot neglect it.
So I think sir has given the message very clear. Triaging is the backbone of our emergency services. Now coming to Dr. Pradhan, sir, about all the investigations, emergencies, especially in surge conditions, misidentification, sample swaps. These are not very uncommon. How can we prevent them? How can we develop a system to prevent them? And also, like a critical result identification, action quick taken, all these things, we want your opinions.
Okay. Taking appropriate sample specimens prior to patient treatment are essential in certain conditions, or most of the conditions you could say. And while taking the samples, the nursing staff has to make sure that they label the patient vials while taking the specimens. Otherwise, what will happen? There will be swapping of samples. Means sample will be misplaced, or there will be mislabeling of samples, which can lead to erroneous results and mistreatment of patients. So labeling at the time of collection is essential. Next is, I think, you said about critical results. Okay, critical result notification is done from the lab itself to the treating physician. The protocol says all critical results has to be notified to the treating physicians within 30 minutes of validation of report, or once it is confirmed that it's a critical result. Once the result is notified, there has to be action on this result because they are critical, and patient needs to be treated based on this result urgently. Otherwise, this can lead to mortality of or this can lead to death of the patient, or morbidity, high morbidity in the patient. So after getting the critical results, which can maybe over telephonically, or can be SMS based, can be other WhatsApp based, depending on the HIS which is supporting this. Once you get the critical result, there has to be action taken on this critical result. Has to be preferably as early as possible for the patient. And documenting this also is important, that when the result is being given to you and you are taking action based on this critical result. This is essential for legal purposes also and for accreditation purpose also. Both are essential. And the important part is that once you get the critical result, the action has to be taken based on this result.
Madam, sir.
We had the same problem, this wrong leveling and then critical result identification. So it has to be happened for us 10 years back. Then 10 years back, we started a digital barcoding system. So previously used to write on the tubes the name and hospital number. So we stopped doing last 10 years. So that wrong sampling stopped now because the barcode system which has prevented. And critical care, what happened, the lab, once it is abnormal, which is critical, we have told them, like what is the sodium value, what is the potassium values, what's the counts, what's the hemoglobin. We ourselves identified, told the lab technicians, they have to ring up and tell our emergencies. And our emergency, whichever nurse and doctor pick up the phone, because we have around like 40 nurses working, 25 doctors are working. It's very difficult to find out which doctor has seen that patient. So they will pick up, any nurse or doctor they will pick up, and we have a WhatsApp group. So we'll put immediately this WhatsApp group, our emergency WhatsApp group, that this patient, this is the hospital number, potassium is 7.1. And then immediately who has doctor or nurses assigned for that, they will take the actions and will put back in the WhatsApp group that treatment has been done. So, and the one associate professor in charge of the WhatsApp group, whenever notification come, is in charge that things are followed, things has been done, it has been documented. So one consultant on floor also responsible for that along with the junior doctor or SRAP.
Thank you, sir. So that is a very, very good thing regarding the safety of the patient and improvement of quality. We can minimize our errors. Can I come back to Ishani ma'am about the identification? Often the patients come to the emergency and we have to start triaging them before the identification documents are made. So this all barcoding and everything will come after identification. So any important point we can do in the emergency for the identification process to be carried forward earlier.
So now what we are doing is we are sending the patient relatives for registration, right? And along with that, the identification band is created. Now before this, the patient relatives are very busy finding out what is happening with their patient instead of going to the registration desk. So we can have it manually done to start with. And that should be a mandatory process for all of us in the emergency to write down the name, the age, that we are anyways getting from the patient relatives. We can have that manually documented before we have a system-generated identification and a band is created.
Sir, what do you do in CMC Vellore?
Sir, one question. After triaging, you put on triage bands. Do you write the name of the patient and age of the patient in the triage bands there, initially during triaging?
As soon as patient come, so the registration done within 1 minute time. So that is by default comes. And while the nurses are doing the triage, the barcode arrive within 1 minute. And once the barcode come, when the patient get the tag of priority 1, 2, 3, red, yellow and green, the barcode gets stuck in the handband. And immediately what happened, as soon as the registration done with the coding, so this is, I get in my pager that there is a priority 1 patient. So the consultant and HODs get in their mobile phone any priority 1 who are struggling for life. We get the notification within 1 minute of arrival in the emergency department. So this is, I carry anywhere in the world I go because I know, because this has to disappear within 8 minutes from my screen. If within 8 minutes it doesn't disappear from my screen, I know that there is some problem. So immediately I'll call to the department, there is a priority 1, still screen is on. This is a, you can say it's a AI, but I developed it around 2012. So almost like 14 years back, I developed this software.
So let me come to medication safety. It's a great topic. So can I come to Madam Saraswati about the storage and labeling of the medicines in the ED, especially use of multi-use vials, storage of high-risk medicines, concentrated electrolytes. Then I'll come to Dr. Arithro for the other things.
Thank you, Tariq sir, for giving me this opportunity. Actually, as nurses, we are being taught that emergency demands speed. But I would like to add one word to it, that is, emergency demands safe speed. And it is not, the real challenge of nurses doesn't lie when they give routine patient care. It is when they face any type of code, emergency-like situation, which we have named to act properly as code blue, code gray, code STEMI, or whatever it is. Just think about a situation when code gray-like situation has occurred and 15 to 20 trauma victims have entered our ED, and some teams are busy with blood transfusion, one is busy with preparing inotropes, and other vasopressors and various types of medications. And there is one unlabeled syringe or one drug that has not been diluted in proper manner. What will happen? That emergency situation will not help the patient, because patient doesn't know when they will become an emergency. But they come to us because they trust us that we are prepared. So how we are prepared for this? We follow certain institutions. Great institution like ISMP, Institute of Safe Medication Practices. We are now certified by the Infusion Nurses Society. We are accredited from NABH. We are looking for JCI accreditation. What for? Just to give safe patient care. And what does the safe patient care include? Medication safety is one great part of it, isn't it? So if you look into the principles of medication safety, the first is you should not plan when there is an incident. We have to do a pre-risk assessment. We have to form a HERA sheet, and we have to do the FMEA, failure mode and effect analysis, to identify where our gap lies, to correct those things at that moment of time only, not at the time of incident. And then the next principle lies by proper leveling and storage. So we should have proper storage site. In times of emergency, one should not think that I have taken the adrenaline from the adrenaline container, but due to space scarcity, my people have stored their other things also. So it may lead to chaotic situation. We may lose a patient life. So we should have proper storage system. We should have proper space, first of all, proper cabinets. Nowadays, various color-coded cabinets are there. If it is a high alert drug, you store in this color. If it is a LASA drug, you have to store here. La is separate, Sa is separate. What for? This is all to support nurses and medical fraternity so that they can act very easily, very safely in terms of emergency situation. And when you talk about other situations, like what do we do? Dilution. Now, if you don't have a proper adult and pediatric and age-specific dilution charts available, what this institution have done, they will put an NC to you. Why do they give us NC? So that till now we didn't have. But we will have it, otherwise they will not give us certificate. So that our patient coming next to us, they will be having a safe area where they will be treated. The nurses will not have to think that they don't have to memorize that this drug has to be diluted in this. They know, they will just look at the chart and they will prepare the drug and give it to you. So that is the thing. And recently ISMP has added one more thing. As the medication safety practices, they are aiming at pre-filled syringes. They are telling if you can avail the prepared medication, you don't have to think and prepare and then bring it to the patient side. You can have ready and use medications whenever possible, if it is possible. Why they are aiming at that? So that we can have the correct medicine at the correct dose and in correct dilution. But what Sometimes what we do, we use these pre-filled syringes when they are vacant. Now we take the second drug and we use it. We show that we are saving the consumables, but it is dangerous. We should never do this. We don't know that in a flush syringe, basically we are using pre-filled flush syringe nowadays. And I've seen, and I'm telling my nurses also, that never ever use this pre-filled flush syringe for diluting adrenaline or something else. Nahi, ye to khali ho jata, we can reuse it. No, no need to reuse or no need to dilute with that flush content with the drugs. It is not good also and not effective also. And moreover, it will lead to a medication error. So we should not do it, okay? And then what I will aim at the first part of your conversation today was communication. So in terms of medical situations, just a minute, the use of verbal orders, it should be minimized to how much extent we can. And there should be closed loop communication. If I receive an order from you in times of emergency, that sister, give adrenaline 1 mg IV. So I have not heard, or you should not use ADR. Are isko dopa de do, dobu de do. We should not use like this abbreviations and nicknames. So that is dangerous. So this should be eliminated. This practice should not be there. And we should aim at, if you have told me to give adrenaline 1 mg IV, so I should confirm from you. And after giving also, I should say that, yes, injection adrenaline, 1 mg IV given. And while preparing also, there are 5 persons there. So I should raise my hand, I am preparing adrenaline. So the consumables doesn't get wasted. So these all practices should be there. And we should do regular audits to see that whether our policies are getting standardized. We have created very nice standardized policies, but whether it is getting followed or not. And for this, in order to make them follow, you have to give them training and mock drills, simulations should be done. So this is very, very essential. Otherwise, what sir has told, sample swapping for everything now. NABH and JCI are aiming at that you have to do tabletop exercises, you have to do mock drill sessions. So I think this part we have to strengthen in our organization. Otherwise, we are doing great. My emergency department is...
That is a very clear message. But verbal orders, I think emergency is one place where verbal orders are rampant. We have situations where we can't avoid.
So verbal orders need to be properly made. Like as madam told, the drug name be given in the full, dose, route, and time of administration, whether its dilution is required or not, and time period through which it needs to be infused.
Rantac and Zofer cannot be a verbal order. We have to see that emergency, the situations are really, really emergency. We should have a list. Which all medication can be verbal order?
Actually, what madam is telling, it's very important. To make it gist, 4 things. So for verbal order or standing order, you should have a list of the drugs. Otherwise, they will not follow. So it's strict. They should be very strict. Which other drugs can be given standing order, which cannot be given. Second, all the drugs, especially the pediatrics one, where you have to calculate, you should have a drug, your
dilution chart,
calculators, drug. So we have done this printed form and kept in the wall, and all infusions also we made it. So every doctor or nurses, how confident also, still they have to see that and they have to check it. And all dangerous drugs, if nurses are loading, 2 nurses has to sign it. And doctors are giving, writing, 2 doctors has to check the dose. So always, that's the way we came out that problem.
Thank you, sir. May I have a just last question? Infection prevention in ED. That is something often you overlook. It's so very crowded. So much people rushing in here and there. Trauma patients, bloods here and there. So how can we prevent infections? Because when these patients will go to ICU, they will develop some kind of infection.
Infection prevention is important in ED, but it's difficult to practice. Practically, it's difficult to practice, especially in a busy emergency department. But again, hand hygiene, isolation of infectious patients, cleaning of environment, safe injection practices and aseptic procedures. You should have a separate aseptic procedure room actually, which we are lacking in present infrastructure. But there has to be a separate room for aseptic procedures. There has to be proper isolation facilities capable of catering to the population, and hand hygiene is obviously important. And your all preventive measures, means proper usage of protective gears is important. But again, I think practically it's very difficult to practice, but it is important.
Sir, I want to tell you, around 2 years back, the hand hygiene and infection control was so poor. The statistics says that only 44% of the people was using the correct protocol for all the procedures. Then we are breaking our head, we gave the training, but it's a mindset. You don't want to do means, you know it that you have to wash your hand, you have to wear gloves, all this, whatever the certain procedures has certain. Then what happened, we put CC cameras in our emergency department, and our QMC and infection control, one nurse will be always seeing who is not doing it. Then you identify the person and call. And once we started calling the person for explanation why it was not done, now our hand hygiene has gone to 92%.
I think that's a very great learning for us.
I would like to add a small thing here. I think what sir wanted to say is discipline is the key. And the discipline can be instilled through policing. But I think if everybody working there in ER are professionals and they know what it is supposed to be like, it should come from within. Wearing a scrub suit, walking out of the hospital, going to the food stall across the state, having food, having chat, and then coming back and walking into the ER, and then attending the next patient in that same scrub suit with that same hand and with that same shoe, and so many other things. This should come from within. And we all need to train ourselves to think in an empathetic manner, where patient is first in our mind, so that we stop playing with their lives.
So I think that's a very fair discussion, and the message is clear to all. We had many other points, but I won't be elaborating because time is short. So these are the things: improved outcomes, thorough regulation is one thing, targeted capacity building of the workforce, ongoing monitoring on which Saraswati Di, Madam, Sir has always focusing on, and the last focus on our continuous quality improvement. Thank you all. Thank you. Any inputs from the audience?
Tarugda, I'll take up the hosting from here only. May I please request Dr. Debashish Dasadhikari to give away the mementos to all the participants. Thank you, Dr. Dasadhikari. Thank you, Tarugda, and all the panelists. Let's welcome Dr. Prithviraj Kuduri, Head of the Department Blood Bank and Transfusion Medicine, to deliver his presentation on Bleeding against the clock, rethinking massive transfusion. Also, please welcome on stage the panelists, Dr. Ipshita Nag, Consultant Blood Bank and Transfusion Medicine, Dr. Ashish Krishna, Consultant General Surgery, Laparoscopic and Robotic Surgery. Dr. Ashish Krishna is, yes. Dr. Namrata Parida, Consultant Obstetrics and Gynecology. Dr. Rashid Raza, Consultant Accident and Emergency. And Dr. Manas Banerjee, Associate Consultant SICU. Thank you so much.
A very good afternoon to the honorable dignitaries on the dais and off the dais. So without further ado, I'd like to jump into the topic. So massive transfusion, I'd like to address in the next few minutes two primary questions. Why does your patient bleed and what you should do to stop it? So hemorrhage is the most common cause of preventable cause of death after trauma. And the most common deaths happen in the first 3 hours. So this is the reason why previously, massive transfusion, the definition was that in the first 24 hours, more than 10 units have to be transfused, that is whole blood. That was the previous definition for massive transfusion. But because of this thing, that the patients are dying within 3 hours, the definition became more dynamic. Like 150 ml per minute bleeding should be there, or more than 3 to 4 units per hour bleeding should be there. So the definition in turn became more dynamic. And also, 1 in 3 of these patients, the massively hemorrhagic patients, they present with coagulopathy. So why they actually bleed is because previously there was the triangle, bloody vicious triangle. So when the patient is bleeding, so after the bleeding, there is hypoperfusion, which leads to accumulation of acids and lactic acidosis is produced, which again in turn leads to coagulopathy. And because there is hypoperfusion, sometimes the and because of shock also, the thermoregulatory center of the brain is dysfunctional, as well as we give fluids from outside, which are at room temperature. So all these interplay will cause hypothermia, and hypothermia again causes dysfunction of the enzymes, again leading to coagulopathy. And because this coagulopathy is there, bleeding is going on, we give blood products which have citrate in them. So that citrate binds with the calcium and causes hypocalcemia. So each of this diamond, the corners of the diamond, each of them feed the others. So it's a never-ending spiral, which causes more and more bleeding to the patient. So our action should be to cut the corners of this diamond. So this is the reason why the patient is bleeding. And what we should be doing to stop this is, so there's a paradigm shift from previously in massive transfusion protocols. They used to be crystalloids, large volumes of crystalloids used to be given. They used to wait for the lab results. And blood pressure has been given immense importance. But now today's damage control resuscitation protocols, they advise us to minimize crystalloid. Blood is the fluid of resuscitation. So a bleeding patient, blood has to be given in a proper ratio. The empiric balance should be followed. And permissive hypotension is allowed in the new protocols. I don't know how low we can go. Maybe the experts can throw some light on that. And usage of tranexamic acid also is included. So blood product should be given in the ratio of 1:1:1. That is, for 1 PRBC, 1 platelet, and 1 plasma should be given. There has been a proper trial. Proper trial means pragmatic, randomized, optimized plasma and platelet ratios. So that trial has clearly stated that if the PRBC is increased, like 1 plasma, 1 platelet, and 2 PRBC, if they are given at a set time, this has no difference. The mortality as well as morbidity, as well as the hemostasis being produced, is almost quite similar to 1:1:1. So whenever a bleeding patient is there, we have to give the blood products in this ratio 1:1:1. And tranexamic is a drug. It's a wonderful drug, and its most highest efficacy is seen in the first 1 hour of the bleeding. And it is effective up till 3 hours. More than that, no benefit is there. And this one, in women with PPH, tranexamic acid is very beneficial. The usual practice is 1 gram IV over 10 minutes. The second dosage can be given over 8 hours. And the other thing is, whole blood has made a comeback. So previously, when there was a bleeding patient, whole blood used to be given. Then we shifted to the concept of components, reconstituted whole blood. Again now, whole blood, some studies are showing that whole blood has lower mortality, almost as high as 40% lower mortality compared to components. But the problem with whole blood is the inventory management is very difficult. Whole blood, the shelf life is only 21 days, and apart from trauma patients or exchange transfusion, any other patient we cannot give it. And the unit, if we can include this in our protocol, we can save 1 O unit PRB whole blood and put it in the refrigerator only for the trauma cases after doing the titers. So other new things that we have started using and all over the world they are using are viscoelastic testing, that is TEG and ROTEM. So this one, it will give us a global picture. PT and APTT, those tests will stop when the clotting starts. But these tests, after the clotting started, how strong is the clot and how it is getting fibrinolyzed, all this information, the global picture of the patient, we can get from it, and we can pinpoint which component should be given at what sequence, what dosage. We can take the right decision based on this. And fibrinogen. See, fibrinogen is the factor if a patient is bleeding. The first factor to fall down is factor 1. Suppose a patient is bleeding up to 142% of the total blood volume. It will reach the critical value. But whereas the other factors and platelets, he or she has to bleed up to 200% for them to fall to the critical levels. So this is the first factor to fall. But the recent studies, Cryostat 2, they have shown that empirically there is no need for us to give fibrinogen to all the bleeding patients. Only if there is evidence of hypofibrinogenemia or in the viscoelastic test, if the clot strength is reduced, then if with those evidence, we can give fibrinogen concentrate or cryoprecipitate. Then calcium. So as I've already initially told, hypocalcemia is also produced. The main cause of that is the blood products that we infuse. All the blood products contain citrate. So this citrate binds with the calcium, and the fall in the hypocalcemia is a transient one. So only the ionized calcium is reduced. And the transient, after that, there are 2 kinds of calcium in the blood, ionized calcium and protein-bound calcium. So the initial ionized calcium falls when we give the blood products. So for every 2 sets of MTB boxes, 1 10 vial of injection of calcium can be given. This we follow in therapeutic plasma exchanges and apheresis of the patients, like we are doing STP. We infuse them with calcium. We can clearly see in such scenarios that they'll be complaining of perioral numbness, tingling sensation of the fingers. So signs of hypocalcemia will be there. Then we start the infusion. Even after calcium infusion, if it's not corrected, that means hypomagnesemia is there because citrate binds with calcium as well as magnesium. So if a patient's symptoms are not corrected with the calcium, we can go with magnesium. So when to activate MTB, I won't take much time because the experts will be talking about this one. So we usually follow the ABC score. And in postpartum PPH, fibrinogen will be falling down. And the other thing is, nowadays, the newer direct anticoagulant, direct oral anticoagulant drugs have started. So be it the direct thrombin inhibitors, dabigatran, or factor 10 inhibitors, apixaban, rivaroxaban, these are there. We have specific antidotes for that. Or else, for the direct 10A inhibitors, we can use PCC also, 4-factor PCC, that is the prothrombin concentrate complex, to arrest the bleeding in such cases. So the take-home points is there that we should give the blood in a balanced ratio and utilize all the other amenities like tranexamic acid, fibrinogen concentrate, based on the evidence we have, and guard the diamond and stop the source. So I'll dive into the panel discussion. We have an eminent group of panelists, Dr. Ipsita Nag, Dr. Ashish Krishna, Dr. Namrata Parida, Dr. Rashid Raza, as well as Dr. Manas Banerjee. So the first question to Dr. Ipsita Nag is, if a patient, the tech report of a patient who is massively bleeding, the R time is prolonged, the angle is shallowed, and low MA is there, how do you proceed?
So first, let me explain about the TEG. TEG is the thromboelastography, and it is the point of care testing, and it has few parameters. That is the R time, which is what you have already said, that R time reflects the clotting factor. The angle, it reflects the how much the fibrinogen is there, and the MA, it represents the clot strength, which is made up of fibrin and fibrin or the fibrinogen and the platelets. And the last is the lysis 30, that is LY30, which is for the fibrinolysis. So you had said about the prolonged R, a shallow angle, and the low MI. So it is of the hypocoagulable state, and you usually give, means the blood products to be given is FFP, cryoprecipitate, and the platelet as per the weight of the patient.
Thank you, ma'am. So here I'd like to point out that the coagulation test as well as the viscoelastic test, they have a very low positive predictable value and very high negative predictable value. That means if the patient, if the TEG report is saying, that giving a flat line, that means no coagulation, and the patient is not bleeding, we do not treat the patient. These tests should be used only for exclusion. Suppose a patient's R time is 3 to 5 minutes. That clearly means that the coagulation factors are fine and no need to transfuse FFP. So only for exclusion of the causes of bleeding, these tests should be utilized, because there are n number of causes like how they collect the sample, how the citrate is mixed, where they collected the sample, whether the patient is given heparin previously, so, and sometimes there will be cup drop, or how the technician performs. So these tests should be utilized mainly to exclude the causes of bleeding. So next question to Dr. Ashish Krishna. If a patient is on apixaban and needs an emergency surgery, how do you manage the bleeding risks?
Yeah, hello. These days we find such patients quite often, because a lot of orthopedicians and cardiovascular people and even cardiologists, they use these newer drugs. So what can we do is, first of all, we have to see whether the really the surgery which we are going to take is really an emergency or not. We should always keep in mind that these particular drugs, they have a very short half-life, especially as you mentioned about the apixaban. It's only 12 hours. So if we can delay a particular surgery for 12 hours, what we are doing is we are reducing the potency of the drug. So if it is really emergency that we have to take the patient immediately, that what we can do is that immediately we can think of, if in our hospital the antidotes are available, like some, especially 2 antidotes which you have already mentioned, PCC and Endexi, something like that. So if those are available, we can give that. But even if those are not available, we should not forget that our old time-tested things like fresh frozen plasma, as well as, sometimes we can even give tranexamic acid along with that. And few other things which you all help us. So it is not just that antidote is mandatory, but often judicious use of our available products can also help.
Thank you, sir. So these newer anticoagulants, they per se will not cause the bleeding. Suppose some patient is already on apixaban and there's a dengue and platelet count fell down, then they tend to bleed. So these patients for surgery, if it's not an emergency surgery, all these drugs, rivaroxaban, edoxaban, all of them, the half-life is around 10 to 15 hours. So we can wait for 1 or 2 half-lives and then go ahead for the surgery. Or, as sir has rightly pointed out, FFP can be given. FFP can be given for direct thrombin inhibitors, but the volume will be very high, like 8 to 10 units should be given. If not, then PCC is a very good option where very limited amount of vials can be given, but it's expensive if the specific antidotes are not available. For dabigatran, idarucimab can be given. For them, Adinexa alpha can be given. So next question to Dr. Namrata Parida. when do you give fibrinogen concentrate in PPH? What are the indications that you look into?
Thank you for the opportunity. Every patient which is having obstetric PPH, postpartum hemorrhage, shouldn't be given fibrinogen. First, we need to assess the condition. First of all, if the ongoing bleeding is continuous and we can assess that hemostasis is not possible, then if we have monitoring methods to assess the level of fibrinogen, that's the best time. If the fibrinogen level is less than 2 gram per liters, then we have to give fibrinogen concentrate. But if the monitoring is not possible and we can see the bleeding is ongoing, then we need to give a fibrinogen concentrate. And especially in obstetric patient, we need to know that pregnancy is a hyperfibrinogenemic condition. So even if the levels less than 2, which is acceptable in the normal patient, it is not normal for the pregnant patient. Therefore, if the fibrinogen level is less than 2 gram, it's a very depleted condition. So we need to give the fibrinogen in order to tackle the DIC.
Thank you, ma'am. So fibrinogen, the Women trial and Women 2 trial have clearly shown that with evidence, fibrinogen concentrate or cryoprecipitate can be given to control the hemostasis. And so you cannot wait for the close fibrinogen in a PPH because it takes almost 1 or 2 hours, even if it's being done in the same institute. So better to depend on viscoelastic tests. And nowadays we are getting newer viscoelastic tests like rapid take. Normal thromboelastography takes up to 1 hour, but with rapid take, in 10 minutes, we can get the complete global picture of the patient, and we can go ahead with fibrinogen or cryoinfusion. Okay, next question to Dr. Rashid Raja. Which clinical clues make you activate the MTP before any lab is written?
Yes, as working in ER, the main thing depends on the clinical judgment that any patient coming with active uncontrolled bleeding with hemodynamic instability. Rather from that, we use ABC score, which contains 4 criteria like any penetrating traumatic penetrating injury and fast positive patient, heart rate more than 120 and blood pressure is systolic blood pressure less than 90. And apart from that, we can use short shock index also, which is heart rate divided upon systolic blood pressure. If it is more than when the MTP is indicated, and ongoing loss.
Thank you. So ABC score is used to activate the MTP. So here we have to remember that once the massive transfusion protocol is activated, so the blood bank will be ready and it will be issuing products till it is been terminated, until it is stopped. So next question to Dr. Manas Banerjee. In the ICU, how do you separate surgical bleed from coagulopathic bleed, postoperative bleeding?
So actually, this is all about emergency today, but the thing is actually we have to work in a very collaborative manner, because whatever the emergency have just initiated, this is about the continuation having in the critical care unit. So maintaining those hemodynamic stability is a pretty concern. We are encountering with the trauma patients or the post-surgical patients, so those are very, so we have to evaluate what of the amount of resuscitation have been done in the ED, or in the OT, what is the amount of volume has been given to the patient, or whatever amount the blood loss that is given to the patient. So whether appropriate amount of FAP or blood powder has been transferred during the OT or not, or in the ER. Again, we have to see same thing in the ICU setup whenever they come to the ICU. So we have to see there are lots of drain and ICD there in place, so where there is any draining from there is any active draining, bleeding occurring or not, or the patient hemodynamic stability is maintaining or not. So you see, if there is patient is not being hemodynamically stable, irrespective after surgical or ED interventions, then we have about thinking something surgical or bleeding from inside or some other sources might be present there. And again, we encounter with the patient having a multiple comorbidity, because we can encounter with the patient of the CKD, having a patient having multiple antiplatelet drugs, having patient say suffering from different sort of diseases, autoimmune diseases. So we have to think about what are the possible etiologies. And if there is a definitively hemodynamic stability following a surgery, then we have to, our prior thinking, the first thinking will go for the surgery. But our first approach will be to talk to the operator, surgeon, who has done the surgeon actually, because he is the first person who can keenly tell how the surgery went actually. So if there is a, he is quite confident and about he can adequately tell us actually the amount of blood loss, we can adequately perfuse or can replenish those blood products. But if there is no as such blood loss to the drain, then it's fine. It's not likely to be surgical. But what happens during this whole ED and OT, these things happening, they give a lot of amount of blood. So what is happening in fact, there is a dilutional coagulopathy pattern also developing during this period. So totally, absolutely, you have to see the monitors, baroparameters, as well as we have to see those premorbid conditions, what are there, and accordingly we have to decide. We have to look about those draining bags as well. So as a whole, a multiple factorial approach is instead taken. And if there is some situations arrives, we definitely take the suggestions and the help of the take to determine what sort of things to be given. That's it from my.
Thank you very much. One more thing, the practical issue that we faced every day. Suppose in the ICU, the patient is not bleeding, but all the coagulation parameters are deranged. Like PTINR is the no coagulation is showing, and viscoelastic showing as a hypocoagulable state. But the patient is clinically not bleeding. So how do you, this is something we face.
No, see, we often encounter this sort of problem, okay? The parameter shows that there is absolutely hypocoagulation is there, but we often see the patient is, if it is hemodynamically stable and there is no immediate intervention needed to transfuse any sort of component, so definitely we'll take the help of the take and everything. Eventually, even the take insists something like that, we need to transfuse, we can in ICU setup continue the monitor patient for each second by second. So we can take the clinical call upon the very need of the patient, not on the certain parameters, because sometimes those parameters can be taken, where say sister has taken those blood sample in a dilutional or through the vein from where it is being IV fluid we are giving, right? So it is a continuous assessment process, and we have to transfuse whatever the need of the time. A mere abnormal reading of a parameter cannot decide the transfusional role.
So take home point is don't treat the patients, but don't treat the numbers. So okay, next question to Dr. Ipsita Nag. The different viscoelastic tests take versus ROTEM versus the CLOS method of fibrinogen estimation, which one do you trust and when do we use?
We have to know that what are the uses and the limitations of the each test. Thromboelastography, this is the point of care test. ROTEM is also in the same principle of thromboelastography. It is also a point of care test, but in the one more advantage is there that you can separately you can evaluate the intrinsic pathway, the extrinsic pathway, the fibrinogen and the hyperfibrinolysis. But CLOS fibrinogen, this is the gold standard. It is the lab test. It is not the point of care test. So, but it is the gold standard for the measurement of the functional fibrinogen. So, if we know the where to use, TEG and the ROTEM can be used for the cardiac surgery, liver transplant, like as we said also in the massive transfusion, what components has to be transfused. And the CLOS fibrinogen, it takes around 1 to 2 hours, and it is a lab test, and it only means, means checks the functional fibrinogen. So if we know the uses and the limitations, all tests we can use it efficiently.
Thank you, ma'am. So both the tests, thromboelastography as well as ROTEM, are based on the very same principle, but ROTEM has additional features like INTEM, XTEM, FIPTEM. Those parameters are given. INTEM represents the intrinsic factor, XTEM the extrinsic pathway, and FIPTEM shows the strength, clot strength because of fibrinogen. And one important study I wanted to point out is, ATATIC study means it compared empiric treatment, like formula-based treatment for massive hemorrhages versus goal-driven treatment. So in that it showed that goal-driven means using viscoelastic tests. So when we are using this point-of-care tests and treating precisely, also not much survival benefit is there. The main sole reason for that is that these tests, by the time the results come, it will be 1 hour. But formula-driven are faster. So ideal method to treat massive hemorrhages would be a hybrid of starting with an empirical treatment and follow up with the goal-driven treatment. So next question to Dr. Ashish Krishna. Diffuse oozing intraoperatively despite good surgical control. What will be your next steps?
I hope every surgeon will dread this particular thing because it goes out of hand from the surgeon. But still, the first and foremost thing is, whatever you think, still see once more that you have not missed any, slipped ligature or anything. And if you are very sure that even after checking that still there is, oozing which you cannot explain, then first and foremost thing that should come in our mind is that we should see to the deadly triad, that whether that patient is adequately warm or not. These are some of the things which can alter the, clotting and thrombosis picture. Another important thing is that the parameters, we can ask the NSS about the acidosis, because some of the patients might be in sepsis and they might develop acidosis, and which will ultimately lead to coagulation disorders. Before we further search for any exact cause, what we can plan is that immediately we should send blood samples for our coagulation factors so that we can decide what actually can be done instead of giving the whole blood. In particular, what are the factors which we are lacking? And I think TEG can also help at that time. So what is the most important part is that the team should be properly communicated, which includes the NSS, which includes the other our technicians, etc. Because the most important part will be to, give as soon as possible what the patient requires. It should not be much, it should be minimum, but it should be adequate. So components have a greatest role, I think, in such situations. Thank you.
Thank you, sir. So nowadays, some surgeons are using sonoclot as a screening method. Sonoclot is also a viscoelastic method. Intraoperatively, inside the OT, they're having it, and they're using it to screen. It will just give us the clotting time, initial clotting time, so we can know whether any factor is deficient or not. And one more thing, from blood banker's point of view, even transfusion reaction also will be causing oozing. So if there's hypotension also, then we can think in that lines. Next question to Dr. Namrata Paridhar. Cryoprecipitate or fibrinogen concentrate in obstetric hemorrhage?
Well, if the fibrinogen level is less than 2 gram, then we need to give the patient either cryo or fibrinogen concentrate, because now the FFP is not going to work. And in between two, which one is preferable? As per the studies, both the results are same. Only both of them have some pros and cons. Like for cryoprecipitate, it is easily available and it is less expensive, universally accessible. But the problem with cryo is the volume of infusion will be more, and already the patient is hemorrhaging. Definitely for volume replenishment, we have already given the patient a lot of crystalloids along with other units of blood. And another problem with cryo is it requires thawing time of 20 to 30 minutes, which takes more time. But in case of fibrinogen concentrate, if it is available, then there is no thawing time is required, and the fibrinogen amount is, the raise in the fibrinogen is very standardized as compared to the cryoprecipitate. One problem with this thing is the expenses and the universal availability of the product. Otherwise, both of them generally give better results, but as cryo is more readily available, we prefer giving cryo.
Thank you, ma'am. So both cryo and fibrinogen concentrate are equally efficacious, but fibrinogen concentrate is readily available it's in a lyophilized vial, and over 10 minutes immediately infusion can be given. But at the same time, it's very expensive. Each vial will be costing around 17,000, 16,000 like that. Cryo is less expensive, but the waiting period is more, where we have to thaw it and it has to come here. And the quality is not standardized. Like each donor will have different levels of fibrinogen. So next question to Dr. Rashid Raza. How does early MTP activation actually change outcomes?
The MTP activation, it acts as a time buying and bridging between the definitive hemorrhagic control, and it also helps in, it prevents the patient from dying of the lethal triad of the like coagulopathy, hypothermia and acidosis, and it reduces the crystalloid overload and helps in the target oriented treatment of the patient. As with starting of the MTP, as we start MTP, we also send TEG, and from that we can treat the patient with the target therapy.
Thank you very much. So, last question to Dr. Manas Banerjee. What is your approach to coagulopathic bleeding in the ICU?
Generally, there oftenly happens the coagulopathy in the ICU setup, most commonly likely patient having a MODS scenario or having a severe trauma leading to severe hemorrhage, that most commonly going for the coagulopathies, but we recently has balancedly stopped those transfusions recently. So take guided blood transfusion nowadays we recommended so much. Definitely any patient coming to the ICU, so generally bedside procedure like those gases, routine. If basic necessary patient is very much hemodynamically unstable, then in those scenarios PRBC can be considered. Else, like say those anticoagulants and those neofactors, and recently we are using those take-guided fibrinogen concentrator to control those bleeding part. Okay, so once those target those specific, actually we can make out the absolute deficiency part. So targeted approach is very much necessary, because the more and more we will transfuse to the patients, more coagulopathy will develop instead of correcting them. So very precise and definitive corrections is needed indeed.
Thank you very much. I'd like to thank all the eminent panelists. So take home points I'd like to tell you are that the coagulation tests have very high negative predictive value, very low positive predictive value. Fibrinogen, unless you have evidence, don't try to correct it. And ionized calcium, the relation between mortality and ionized calcium is a parabola. So at one point, exact value, if you get it, you should not overcorrect it, because overcorrection again leads increased mortality. Thank you very much. Thanks a lot.
Thank you so much, Dr. Prithvi, and thank you to the panelists. May I please have Dr. Deepak Kumar on stage to give away the mementos to our moderator and our panelists. Dr. Ashish Krishna, please come forward. Kisse dilwane? Okay, Dr. Prithvi Raj. Giving away to Dr. Ashish Krishna. Thank you so much. Dr. Manis Banerjee. Dr. Ipshita Nag. Dr. Namrata Parida. And Dr. Rashid Raza. Thank you so much, doctors. Thank you, Deepak sir. Block the pain, skip the opioid. Is regional anesthesia the ED's best kept secret? May we please have Dr. Arindam Chatterjee on stage to give this presentation and have a discussion along with panelists, Dr. John Acera, Dr. Ashish Bongobash, HOD Chief and Chief Anesthetist, Department of Anesthesiology, and Dr. Taruknath Tarubdar, Deputy Medical Super.
Good afternoon, everybody. So the plan for this session is I'll first present the topic, and then we'll try to have a short discussion on the topic with our eminent panelist. So block the pain, skip the opioid. Is regional anesthesia it is best kept secret? So I'll start with a case scenario. 65-year-old female who has a history of fall at home and presented with a neck of femur fracture. The patient is obese, hypertensive, COPD, and having a pain VAS score of 10 on 10. So Dr. Ravi is the attending emergency physician. He took the history, did relevant clinical examination, confirmed the diagnosis, and informed the orthopedic RMO to come. Now he has to control the pain. So first he gave injection IV paracetamol 1 gram, gave NSAID, that is injection diclofenac. Then, the patient is still having a good amount of pain with a VAS score of 7. So he decided to go for strong opioids in the form of injection fentanyl. So he gave injection fentanyl 50 microgram followed by another shot of 50 microgram. So with that, the pain is controlled. But now he started seeing few problems. First, the patient became sedated and a little confused, difficult to rouse from on verbal stimulus, but on deep pain stimulus, the patient is responding. The family became concerned about this drowsiness. There is difficulty in assessment when the orthopedic RMO came because the patient is sedated and not exactly responding the way he wants, like the clinical examination and the history taking. Now, Ravi was also concerned that there is a risk of aspiration as the patient is sedated. And the respiratory rate is also, he found that respiratory rate is also on a lower side, like 6 to 8 per minute. So now he has a concern that whether this sedation is because of the fentanyl effect or it is because of the respiratory repression leading to CO2 retention, leading to hypercapnia, that is causing confusion. So whatever the patient, he shifted the patient to SDU with monitoring and continue opioid analgesia. So the same scenario, but now one thing has changed. Now Dr. Rabi has attended an emergency medicine conference workshop where he learned about regional anesthesia blocks. So this time, everything was same. This time, he went for IV paracetamol and then he planned for a block. Which block? So he basically first activated the acute pain management protocol, asked to prepare the block trolley, prepare ultrasound, and then gave ultrasound guided fascia iliaca block. and the patient became comfortable within 15 minutes. The patient was alert, oriented, and early and reliable history taking and examination was possible. Family is reassured because pain has subsided, clear communication is possible, and opioid-free analgesia continued through to theater. So coming to the problem, what is the problem here? So pain is the #1 reason patient come to ED, and opioids are still the default answer. For decades, the reflex response has been systemic opioids. It is fast, familiar, and readily available. But the downstream costs are now impossible to ignore. The first and foremost is the side effect burden. Opioid causes multiple side effects, which are sedation, respiratory depression, nausea, and delirium. I'll talk about later in the next slide. But another important thing is the misuse and dependence. It has been seen that even short opioid courses initiated in the ED are linked to persistent use and long-term dependence risk. Another problem is the masking, that is systemic analgesia blunts pain everywhere, delaying examination, diagnosis, procedures, and safe disposition. Another problem is one size fits none. Like a hip fracture and a renal colic gets the same drug class despite very different mechanism of pain. So coming to what are the side effect burden of the opioids. So first is sedation. Opioids causes dose-dependent and sequential sedation. Especially vulnerable people are the elderly patients, where opioid-related confusion delays mobilization. Also, the patients who are having cognitive dysfunction, there is increased risk of confusion and delirium. Respiratory depression, that is the single biggest safety concern, especially in patients who are having obstructive sleep apnea, obesity, or frailty. Another issue is the nausea and vomiting. That is the most common reason for delayed discharge and patient dissatisfaction. Another issue is ileus or GI hypomotility. Opioid slows gut transit, leads to opioid-induced constipation. And cardiovascular effects with higher dose, it can cause bradycardia, hypotension, chest wall rigidity. Another issue is the pain biology reasons. There are two things that happen when opioids are given for a longer duration. That is, one thing is called opioid-induced hyperalgesia. Here, paradoxically, opioid can sensitize pain pathways, making patients more pain sensitive post-operatively. And usually it happens with a higher dose and prolonged exposure. And another thing that happens is the acute tolerance. Here, there is a rapid reduction in the opioid analgesic effects that can develop within same day. And population-specific drivers are there, like this. All these side effects burden are particularly felt when the patients are elderly, frail patients, patients with obstructive sleep apnea or COPD or severe respiratory disease. Also, patients who are opioid tolerant or having opioid use disorder, their systemic opioids are both less effective and having higher risk. So the problem, that is the burden of opioids, that we understood. Now coming to the three different concepts, or rather we say the recommendations. So one is ERAS. So ERAS means Enhanced Recovery After Surgery. It is a standardized, evidence-based, multidisciplinary perioperative care pathway designed to help patients recover faster with fewer complications after surgery. The core philosophy here is that instead of the older model of accepting long recovery, prolonged fasting, heavy opioid use, and slow mobilization, ERAS bundles together many small evidence-based interventions across the whole surgical journey, that is pre-op, intra-op, and post-op. And all these two leads to cumulative effect, which meaningfully having a meaningfully faster return of bowel function, earlier mobilization, and shorter length of stay. Now, why I am talking about ERAS? So, ERAS recommends opioid-sparing analgesia. Why? Because opioids work against nearly every ERAS goal. That is, opioids produce ileus, which delays return of bowel function. Opioids causes sedation, delirium, which delays mobilization, and causes nausea, vomiting, which delays oral intake and discharge. So what it recommends? It recommends regional blocks. Regional blocks like epidurals, tab blocks, fascia iliaca, PECs, serratus anterior blocks. These are now default component of ERAS. Now why ERAS in emergency department? Because emergency medicine physicians are the pre-operative physician. So the ERAS should be initiated from the ED, and the regional blocks also should be initiated from the ED. Coming to the second concept, that is the concept of multimodal analgesia. So what it means? It means that instead of giving one drug with their highest dose, give multiple drugs at the same time which have different mechanism of action. So here we use non-opioids like paracetamol or NSAIDs or other NMDA receptors adjuncts like ketamine, lidocaine infusion or dexmedetomidine and opioids. But the most important thing is when the pain is blockable, or we can say the eligible pain, block eligible pain, there it highly recommends regional anesthesia. That is the nerve blocks that are most effective, most underused, and can zero out specific pain source with no systemic side effects. And third is the concept of WHO pain letter. Now, the original WHO pain letter was introduced for cancer pain in 1986, and it has 3 steps. In step 1, we use non-opioid analgesics. In step 2, if pain is not controlled, then give weak opioids. And in step 3, we give strong opioids. But later, 4th step was included or added, that is different pain interventions like nerve blocks, epidurals, PCA pumps, etc. Now, is it fit for acute pain management? The answer is no. For acute pain management, instead of going step by step, we go top-down approach. Here, the regional block is placed alongside step 1. That is step 4 and step 1 at the same time. And it is used as a first-line strategy for anatomically eligible pain. And it aims to avoid needing steps 2 or 3. There is a weak opioids or strong opioids. And opioids is reserved when the pain is outside the block's coverage, or if as a true rescue analgesia. So coming to the regional anesthesia, what it is exactly? So it is a targeted deposition of local anesthetic around a specific nerve or fascial plane under ultrasound guidance to switch off pain signaling from a defined body region without a systemic drug effects. So the main essence are that it is site-specific, that is, analgesia is limited to that injured region only, no whole body sedation. Second is ultrasound guided, so real-time visualization of nerve, needle, and spread is possible, which improves safety and accuracy. Fast onset, that is, many ED blocks provide meaningful relief within 10 to 20 minutes. And fourth is opioid sparing, that is, it reduces or eliminates the need of systemic opioids. Now, we interchangeably use these both terms, regional anesthesia and regional analgesia. So, are they same or they are different? The difference is the purpose. So, in regional anesthesia, the purpose is to produce complete loss of sensation, often with motor block, to allow surgery or procedures. So, the sensory blocks is dense and usually with no pain perception, and also the other sensory component, that is touch, vibration, also is gone. Motor function is usually lost. Local anesthetic dose, here how we achieve that? We achieve that by using higher concentration or volume of local anesthetic. And clinical use is for surgery or fracture reduction and invasive procedures, like small procedures that we can do in the ED. Whereas regional analgesia, here purpose is to relieve pain while preserving as much function as possible. So here the sensory block targets the pain, not the vibration or touch sensation. Motor function is usually preserved. Here we use local anesthetic dose in a concentration which is much lower than what we use for regional anesthesia. And it is used for acute pain management in the emergency department, post-operative pain control, trauma, refracture, burns, or cancer pain. So coming to the safety profile. So major complications from ultrasound-guided peripheral nerve blocks are rare in experienced hands. The key risks are well characterized, highly predictable, and manageable with standard precautions. The most important complication that we think of is the local anesthetic systemic toxicity. But it is very rare and usually mitigated by ultrasound guidance, aspiration every time before injection, and don't cross the recommended dose, that the weight-based recommended dose. And in case it happens, intralipid or lipid emulsion should be available. Second is nerve injury. It is very uncommon and usually transient, and usually can be avoided with real-time visualization and avoiding intraneural injection. Block failure. Block failure can happen, usually happens when the operator is less experienced, but it can be managed by structure protocol, supervision during the learning curve, and backup analgesia plans. And the last but not the least, bleeding and infection. These risks are minimized with sterile techniques, and most ED blocks that are recommended are superficial, single injection procedure, and having minimal risk of bleeding and infection. So there are many blocks that can be possible, but we recommend 5 blocks every ED should have on speed dial. So why these blocks? Because these are the blocks which are easy to learn and having a very good safety profile, and caters most of the patients that comes to ED. So first is the fascia iliaca block, second is the serratus anterior block, which is a truncal block, and forearm block, digital nerve block, and interscalene or supraclavicular block. If you see among these blocks, serratus anterior block is a truncal block, whereas fascia iliaca block is a lower limb block. Forearm block and interscalene are for upper limb, and digital nerve block is for both fingers and toes. Coming to the first block, there is the fascia iliaca block. The fascia iliaca compartment block is an ultrasound guided fascial plane block in which local anesthetic is injected beneath the fascia iliaca. So the indications are neck of femur fracture, intertrochanteric and subtrochanteric fracture, femoral shaft fracture, and hip dislocation. So nerve targeted here is the femoral nerve and lateral femoral cutaneous nerve of the thigh. Obturator nerve is sometimes can be targeted or sometimes it is missed. The probe is usually kept below inguinal crease horizontally parallel to the inguinal ligament, and the needle comes from lateral to medial side, and the usual dose is 20 to 40 ml of 0.25% bupivacaine or ropivacaine. Coming to the second block, which is a truncal block, serratus anterior block. It is an ultrasound-guided fascial plane block in which local anesthetic is deposited around the serratus anterior muscle. There can be two ways. One is to deposit the nerve, local anesthetic above the serratus anterior, that is in between latissimus dorsi and serratus anterior, or it can be under the serratus anterior. The indications are multiple refractures, flail chest, and chest wall contusion. Here, the targeted nerve is the lateral cutaneous branches of the intercostal nerves. Probe position is mid-axillary line at 4 to 5th rib. Local anesthetic dose is 20 to 40 ml of 0.25% bupivacaine or ropivacaine. Coming to the next block, which is a forearm block, forearm nerve block. So it is a fantastic block. This block is a distal peripheral nerve block that provide anesthesia or analgesia for injuries and procedures involving the hand, wrist, and fingers. So this area, hand, wrist, and fingers. It preserves motor function, avoid brachial plexus block related complications, and provide targeted opioid sparing analgesia. So the indications are different hand and finger procedures like finger laceration repair, nail bed injuries, hand laceration, finger dislocation reduction, and many more. Here the targeted nerve are all 3 nerves of the hand, that is median nerve, ulnar nerve, and radian nerve. Probe position is usually on the volar distal forearm, 5 to 10 centimeter proximal from the wrist skin crease. And the targeted nerve are found, the median nerve is found in between the layer of the flexor digitorum superficialis and flexor digitorum profundus. Ulnar nerve is found in close proximity to ulnar artery, whereas the radial nerve is found in close proximity to radial artery below the brachioradialis. Local anesthetic injected here is 3 to 5 ml of 0.5% bupivacaine or ropivacaine. Coming to digital nerve block. Digital nerve block is one of the most frequently performed regional anesthesia technique in the emergency department. It provides rapid, reliable anesthesia of an entire finger or toe without distorting the wound, making it ideal for trauma and minor procedures. Indications are finger laceration, fingertip injuries, nail bed laceration, drainage of paronychia or phelon, foreign body removal. Nerve block here is done at the base of the finger, just distal to the metacarpophalangeal crease. And the targeted nerve are 2 palmar and 2 dorsal digital nerve. Local anesthetic injected here is 1 to 2 ml of 0.5% bupivacaine or ropivacaine. Coming to the last block, there is the interscalary and supraclavicular nerve block. So this block targets the same part of the nerves, that is the brachial plexus. But there are a little difference. The interscalary block targets the root, that is C5, C6, C7, nerve root of the brachial plexus, whereas the supraclavicular targets the trunk and division of the brachial plexus. So interscalary blocks when to do? When there is a shoulder pathology, that is the shoulder or proximal humerus injuries. Also it covers the lateral 1/3 of the clavicle. Main limitations is phrenic nerve block. So use caution in patients with limited pulmonary reserve. Usual dose is 10 to 15 ml of 0.25% bupivacaine or ropivacaine. And for supraclavicular block, it covers most of the upper limb. So the indications are from mid-shaft downwards, like mid-shaft of the humerus downwards, like forearm fractures, wrist fractures, elbow fractures, radius ulna fractures, etc. Small but important risk of pneumothorax is there with this block, so meticulous ultrasound technique is essential. Local anesthetic dose is 15 to 20 ml of 0.25% bupivacaine or ropivacaine. So coming to the paradox, that why it is still the best kept secret in the ED. Regional anesthesia has been part of the anesthesia toolkit for over a century, and ED-specific literature has grown for 2 decades. Yet, in most emergency departments worldwide, it remains the exception rather than the rule. It is widely proven. Decades of anesthesia and emergency medicine literature support safety and efficacy, but it is rarely the first line. Most it is still default to systemic opioids for eligible painful condition. And it is also unevenly taught. Training exposure varies widely across emergency medicine residency programs. So the problem is not the evidence. Evidence is there. Problem is in the adoption. What data actually shows? It shows that it steadily decreases the opioid consumption, consistent reduction in systemic opioid requirements, and rescue analgesia use. Also, the length of stay is reduced. It produces comparable pain relief. Peripheral nerve and facial plane blocks achieve pain control similar to or better than systemic opioids for eligible injuries. And it preserved mental status, that is site-specific analgesia, avoids the sedation and cognitive clouding that complicate reassessment, especially in older patients. So if the evidence is strong, what actually in the way? So we found these things, there is the training gaps. So first is training gaps, that is inconsistent exposure to ultrasound-guided blocks during residency and CME. Time pressure, that is perceived long procedure time in a crowded, high turnover department. Third is equipment access. Ultrasound machines and block trays not always available at the bedside. And fourth is the lack of leadership in changing practice, unclear scope of practice policies, and reluctance to shift long-standing habits. So what is the path forward? What can be done? Making regional anesthesia the default for eligible pain and not the exception. So how to do that? One way is to find the RA champion. So an RA champion is simply a designated clinician, usually an emergency physician who takes the leadership in RA adoption. He plans protocols and starts training and structured training. Structured training is simulation labs, cadaver workshop, and supervised practice built into emergency medicine curriculum and CME. Third is point-of-care ultrasound availability, dedicated block trolleys and focused access embedded in triage and resuscitation bays. And fourth is regular audits and tracking the improvements. Audit of opioid use, time to analgesia, and block utilization rate, patient satisfaction score. This should be fed into the outcome results, and that lead to sustained funding and improvement. So the key take-home messages are that opioids are not the only or always the best first-line analgesia for eligible emergency department pain. Regional anesthesia offers comparable or superior pain control with a favorable safety profile. A small set of blocks like fascia lacca, serratus anterior, forearm, digital, and interscalary blocks covers the majority of the ED use cases. The barrier is adoption, not the evidence. And training, equipment access, and protocols close the gap. And last but not the least, every emergency physician can build these skills. It starts with the next eligible patient. So these are my literature. So with that note, that's all from my side. And now I open for discussion. So sir, first, I would like to know what is the status in your places, like whether this it is the block is first line or it is the still a secret.
So, so I'm happy to report that we do regularly use these blocks in our emergency department. Particularly, we do use the fascia iliaca block for patients that have hip fractures. Our ultrasound team, we have ultrasound credentialed physicians in our emergency department, and we do call them when they're around if we have a patient with a hip fracture, and they routinely perform this block, and our patients are usually very satisfied with it. The other two blocks that I would add that you did not mention in your talk are oral blocks that we use for maxillofacial injuries and facial laceration repairs, like the inferior alveolar block or the infraorbital nerve block. We use those routinely.
Infraorbital mental blocks.
Yeah, when we're repairing facial lacerations. But those are probably the two that we, and the digital blocks are probably the ones that we use most commonly in our emergency department, and we teach them routinely to our residents, both in New York and here in India.
Okay. Sir, I would like to know that how you choose your patients. How can you choose your patients whom to give these blocks? Is there any plan?
Like what?
Or any recommendation?
Like what you have said, like your first patient, like 70-year-old comes with a fracture and at the middle of the night. So he is the perfect candidate for a block. An analgesic dose of opioid can kill that patient, and a block can let him survive. So these are, we have to, means most of the adult patient who is coming with trauma, okay, they can be managed, the pain can be managed with a block. As Dr. John said, even they are doing this for oral injuries also. So blocks are the
So basically eligible pain, that is blockable pain. So whenever there is block is possible, like it is, the pain is in a dermatome of nerve, in a distribution of nerve, and that nerve is blockable. In that case, it should be the first line. If it is not possible, the pain is in such a location that is not blockable by a single nerve injection, in that case, it is better to manage with systemic opioids and other methods. But when the pain is blockable in a distribution or a territory of a single nerve, then this block should be used as a first line.
I think even if we can block the nerve partially also, then also we can have lesser dose of opioids. That will also is going to help us.
Yes. Sir, coming to Tarak sir. Sir, is there, if we need adoption of these regional blocks in the emergency department scope of practice, so what is the way? How do you think we can start doing so that regional block becomes not like a secret, rather it is the most common thing or first line for acute pain management?
Dr. Arindam, as you were saying, blocks as per regional anesthesia was not new to us. We were taught by John himself and his team when we were doing MEM way back in 2011.
Yes.
Regional blocks. And as far as I remember, the first emergency such conference we held here had a workshop where the blocks were a component part.
That is what is required,
yeah.
Right?
Now in US, I think I was reading a paper that in 2024 they found that there was training in the emergency residency about this regional analgesia, not anesthesia, analgesia, but there was not uniformity all across the country. So in 2025, the board has finally recognized that that should be a part of the curriculum, residency training curriculum in USA. In our countries, I don't think our emergency medicine residents have that thing as a compulsory in their curriculum. But it can be started. The first thing that can be started is the will and the practice. Well, we have anesthetists on call, so whenever needed, we can come and we can call those anesthetists. We have the USG in our department, so we can proceed with the blocks, learn from the anesthetist, and develop a part of the story ourselves.
Thank you. Thank you so much. Thank you, panelists. That's where I end the session.
Thank you so much, Dr. Arindam Chatterjee. Can we have Dr. Asera and Dr. Tarugda to please give away the mementos to Dr. Ashish Bongobash and Dr. Chatterjee. Thank you so much, doctors. May we please have Dr. Auditro Rai to come on stage for the next section, presentations from DNB residents.
So, good evening, everyone. I request those who are sitting in the back, please come forward. I know it's towards the end, but I want everyone to be slightly getting full of energy to cheer our young physicians who have come to Mission Hospital to make up their future. So this is as Dr. Tirthoda Mukherjee, he has started with the course 2026 with a wonderful video of our efforts in Mission Hospital, Durgapur. So I have requested our young DNB residents to engage themselves to present the most important topic of the day, that is sepsis, which is a team effort, which involves each and every fraternity of our hospital. Even the administration is also involved in sepsis. We are involved in finding the causes of sepsis, why sepsis is happening. So what we have planned out in this session, the topic is racing the golden hour. Are we still failing in sepsis? So what I have thought, it will be started by the emergency resident who initially face the patient, the initial part of the patient. Then when the patient gets shifted to the ICU, they are looked after by our pulmonology and general medicine resident. And then if there is any source of sepsis, deep-seated source of sepsis, which may require a surgical intervention, that part will be taken by our surgery resident. And last but not the least, which matters the most, antibiotics. Antibiotics in sepsis, it will be taken by our beloved Dr. Arkendu Basu. So starting with our emergency resident, and I will call upon on the stage our panelist, Dr. Shantanu Das sir, Deepak sir, Devkant Pradhan sir, Dr. Ashish Krishna sir, and Dr. Tarak Nath. Arkendu, he will be speaking on the top. Sir. Hope everyone enjoy this.
Good evening, everyone. I am Dr. Amit Savan, first year DNB resident from Department of Emergency Medicine. So today I will be presenting Racing the Golden Hour. Are we still failing sepsis? A stepwise ED approach from triage to resuscitation. So before moving forward, let's first discuss about the definitions. Sepsis, it is a life-threatening organ dysfunction caused by dysregulated host response to infection and is defined as a patient with suspected or proven infection and with SOFA score of more than or equal to 2 from the baseline. Septic shock. It is a subset of sepsis in which underlying circulatory or cellular metabolism abnormalities are profound enough to substantially increase mortality. The criteria for it is a patient with sepsis need vasopressor therapy to maintain MAP of more than or equal to 65 mm of Hg and lactate more than or equal to 2 millimole per liter despite adequate fluid therapy. So let's begin with a patient who is a 65-year-old male, arrives at emergency, known case of diabetes, hypertension, complaints of weakness, confusion, fever, and shortness of breath. On examinations, his vitals was temperature was 99, he was hypotensive with increased heart rate and respiratory rate. And motile skin, he was drowsy with delayed CRT. So, why sepsis is still missed in the triage? Out of many reasons, the 5 most common reasons are the patient looks not that bad. That means the patient doesn't present with hypertension because of compensated shock, which patient having normal BP because of tachycardia, tachypnea or mottling. Fever might be absent or motile in patient with elderly or immunocompromised patient or patient who have taken antipyretic drugs. Patient may complain with very vague symptoms like weakness or fall or confusion who are get low triage. The Q-SOFA alone is very insensitive. So waiting for the altered mental status or hypotension, this misses early organ dysfunction. So 5 red flags at the door. Whenever we suspect of some patient with sepsis, we must look for hypertension, tachypnea. Tachypnea is the most sensitive early signs of sepsis. Altered mental status means GCS less than or equal to 14, hypoperfusion, and if any likely source of infection. So, ED approach to sepsis. The first step is to recognize active code sepsis. Patient move to monitor and reassess ABCs. We get access of 2 peripheral large bore IV cannulation, oxygen therapy given if saturation falls below 94, and continuous monitoring with CBG. The samples are taken, 2 blood samples are taken and sent for lactate, CBC, chemistry, liver function test, renal function test, and urine analysis. Then we resuscitate the patient with balanced crystalloids with aiming more than 30 ml per kg for the starting 6 hours. And we again do reassessment after that. And start empiric broad spectrum antibiotics within first hour if the patient has septic shock. So screening tools in the ED. First is Q-SOFA, which includes respiratory rate more than or equal to 22, systolic blood pressure less than or equal to 100, and altered mental status. They are prognostic but not used for primary screening. Next 2, they include 7 vital signs plus level of consciousness plus OT requirement if there. They are preferred in triage screening. SIRS. Parameters include heart rate, respiratory rate, WBC count, blood pressure, and consciousness level. They are acceptable alternative to NIVS2 score. SOFA score. They include 7 organ systems and require lab investigations. They define organ dysfunction but cannot be used as a screening method. Gestalt, which include pattern recognition, patient is sick or not sick, it overrides any score. So we must trust Gestalt. So coming to the Q-SOFA, quick sequential organ failure assessment. Parameters include respiratory rate, systolic blood pressure, and altered mental status. Each I have given 1 point each. So the score 0 to 1 is low risk, 2 is high risk and 3 is high risk. Interpretation is a Q-SOFA score of more than or equal to 2 suggests a higher risk of poor outcome with patients suspected infection outside the ICU. SOFA score. It includes 6 organ system examination. First one is a respiratory in form of PaO2 by FiO2, coagulation profile in form of platelet number, LFT in form of bilirubin, cardiovascular system in form of MAP, central nervous system in the form of GCS scoring, and renal in the form of creatinine. Each of them are given a score in between 0 to 4. A total score ranges in between 0 to 24. A score of more than or equal to 2 defines sepsis. Next to a score. The parameters include respiratory rate, SpO2 scale 1%, SpO2 scale 2 in case of patient having respiratory disease like COPD, supplemental oxygen requirement or not, temperature, systolic blood pressure, pulse and consciousness. Needs to score, any score more than or equal to 3 have medium score, and they need urgent critical review. A score 5 and 6 or more than 7 have very high risk. SIRS, systemic inflammatory response syndrome. The parameters include temperature, heart rate, respiratory rate, and WBC count. Each of them parameters are given 1 score each, and SIRS a score of more than or equal to 2 is the criteria. So clinical gestalt from scores. No score can ever replace the clinical gestalt. Clinical experienced physicians, they can look after overall patient appearance like skin color, patient level of consciousness, pattern of breathing. So we must use both a clinical gestalt and a score. A score is to catch and a gestalt is to override, never the other way around. So which tools works best at the trial? Need to have higher sensitivity than Q-SOFA for infection and organ dysfunction. Since Q-SOFA has higher sensitivity for poor outcome, but it has very less specificity for sepsis. And it can even doesn't tell us about the future poor outcome. So need to score usage, vitals already captured at the triage, so no incremental workflow cost needed. It is a continuous scale, supports escalation ladders and ED assessment. It pairs with a code sepsis, hurdle or protocol, so the score triggers an action. And finally, no score ever replaces clinical gestalt. So moving forward, I would like to tell managing a patient in emergency is always a teamwork. So I would like to call my co-PGT, Dr. Rajat Nahata, who will carry with the sepsis bundle in 2026. Thank you.
So, no, we sepsis bundle.
Hello. So, thanks, Amit, for the presentation. So you will be proceeding with the case, further case. Sir, to the panelist, any further intervention that you want to add in this part?
No, this is, as far the scoring goes, this Q-SOFA, these are quick scoring to know the severity of the sepsis. But detailed scoring SOFA, then Mu scoring, they are give you details, the outcome, severity of the patient. So to an emergency, if you can do, because you need investigation to come. So without investigation, you cannot do SOFA and other score you have told. Now, to get an idea of the severity, you need some scoring, because without scoring, you cannot proceed. So news is a good scoring, and news 2, then SRS score is very, it's not exactly give you the ideas, because systolic blood pressure, heart rate and temperature, it can have a simple fever you can have, TLC count. Need to have a Apache. Apache is not easy for in emergency. You need to do after 1 day, after 24 hours, because all the reports will come, then you can go. Only to assess and to intervene, you need a scoring and quick scoring. I think SOFA, Q-SOFA or SOFA 2 is good as long as the reports comes.
Rest of the things are okay. Interventions.
Okay, sir. Okay, sir. We will proceed.
Just a minute. I should say that.
Rajat, we will go for a quick review of the things.
Auditra, just a minute. I would say identification of sepsis in ED is very, very important to start any intervention. But unfortunately, the introduction of so far 3 definitions have confused the possibility of identification in ED. As you have seen, so many scores, such a thing, first they gave us Q-SOFA, then after 4 years they told no, Q-SOFA is not so good. Now they are telling news, and I don't know whether we are going back to our good old SIRS again.
Okay, good evening everyone. I am Dr. Rajat Nahata, first year resident in the Department of Emergency Medicine. So let us quickly move ahead with the sepsis bundle in the 2026. Firstly, we do the blood gas analysis and measure the lactate. If the initial values are more than 2 millimoles per liter, that's a guide to administer fluids. Blood culture. So blood culture should be taken preferably before administering antibiotics, but it should not delay the application of antibiotics. 2 different sets from 2 different sites should be taken. Antibiotics. Then septic shock patients and definitive sepsis patients should be administered antibiotics within 1 hour. And patients with possible sepsis without shock should be given within 3 hours after a brief workup. Crystalloid. More than equal to 30 ml per kg balanced crystalloids over the first 3 hours for hypotension or shock, and then reassessment is very important. If needed or the patient is still in hypotension, we can give norepinephrine as a first line vasopressor to maintain MAP levels of more than equal to 65. Starting peripherally is acceptable while awaiting for a central access. So lactate, what it really means? We have got 2 types, type A and B. Type A is tissue hypoxia, which is due to anaerobic glycolysis, hypoperfusion, hypoxia and ischemia. Whereas type B, it's mostly non-hypoxic, mainly due to drugs like beta agonists, metformin, in cases of liver failure, malignancy and some mitochondrial diseases. So in sepsis, both the mechanisms, hypoperfusion and catecholamine-driven aerobic glycolysis. So the threshold value is more than 2 millimoles per liter, which is an abnormal, considered as abnormal. Clearance of lactate, it depends on liver and kidney both. It's falsely high in cirrhosis patients and falsely low in AKI patients. So lactate, is it a marker or a target? Points in favor of marker, it's used as prognostic and a trained tool. More than equal to 2 millimoles per liter identifies occult hypoperfusion. Failure to clear predicts poor outcome, and repeat measurement of 2 to 4 hourly during resuscitation is important. So the trend matters more than any single value. We should not chase it as a number. It's not a pure ischemia signal in sepsis. Chasing lactate might lead to fluid overload risk. Peripheral perfusion is also a core target. Lactate is confounded by liver and renal function of the patient. So we need to guide with lactate and treat the patient. So blood cultures and antibiotic timings. As I already said, 2 sets of blood culture from separate sites before antibiotics if feasible. Source-directed workup, taking the urine samples, blood samples, or if any imaging is needed to look for any occult source. Septic shock and definitive sepsis, empirical broad-spectrum antibiotics should be given within 1 hour. And possible sepsis patients without shock, a brief investigation is needed, followed by antibiotics within 3 hours if concern persists. De-escalation at 48 to 72 hours based on cultures, as antibiotics are a dynamic therapy. So the targeted payload radar.
standard empiric coverage, prolonged infusion of beta-lactams after an initial bolus dose is preferred. Unnecessary and anaerobic coverage is avoided, should be avoided. Fungal and fungal biomarkers, so at only if high-risk patients like immunosuppressed or intra-abdominal source of infection. Do not use candida biomarkers to guide initiation. So this is a graph where a bolus dose followed by a continuous infusion should be given to keep the target level above MIC. So next comes the POCUS in septic shock patients, done in Rust style bedside integration. It includes pump, tank and pipes. Here the pump is referred to our heart. So LV contractility, RV size and pericardial effusion if present is seen. Then comes the tank. We look for the vessels, IVC contractility and is respirophasic collapse, showing the volume status of the patient. And in the lung, if B lines are present, we need to stop fluids and might think for fluid overload. We need to look for aorta and signs of DVT and any possible source of infection in kidney, bladder, chest or abdomen or any dermatological source. So IVC compressibility findings. On the extreme left, you can see the IVC is shown as a collapsing, and in the middle, the IVC is taken as normal, whereas in the right, it's fixed or plethoric. So first of all, we need to know where should we see the IVC size. It should be taken at 2 centimeter caudal to RA junction, subxiphoid and long axis. Less than 1.5 centimeter or more than 50% collapse, it supports further fluid administration. More than 2 centimeter and fixed, likely fluid intolerant, so consider for vasopressors. Interpretation is limited in mechanical ventilation patients, RV failure and obese patients. So the trend across boluses, it matters more than a single snapshot. Cardiac contractility findings, we have got 3 phenotypes which drive different action. Hyperdynamic, where the LV is small, walls are kissing and underfed. We need to give fluids. Normal ejection fraction, where reassessment with clinical response and IVC together. And thirdly, in septic cardiomyopathy patients, where the ejection fraction is reduced, LV is dilated, so we need to give inotropes early. So fluid resuscitation controversies. The 30 ml per kg number. Surviving sepsis campaign still recommends more than equal to 30 ml per kg in the first 3 hours, but not as one size fits all mandate. Then comes which crystalloid to be given. Balanced solutions are preferred over the 0.9% saline, as the 0.9% saline or normal saline might cause hyperchloremic acidosis. Reassess or stop. So reassessment is very important. We need to look for perfusion, POCUS and dynamic index, and stop if signs of hypervolemia are present. So the vasopressor escalation staircase. We need to keep in mind the target MAP levels of 65 mmHg, and a permissive 60 to 65 mmHg is allowed if the age of the patient is more than equal to 65. So the first line of vasopressor used is norepinephrine. Then comes vasopressin. Addition of vasopressin should be done rather than waiting for maximum norepinephrine dose. Then comes epinephrine, the final tier. Add if MAP remains inadequate despite any norepinephrine and vasopressin. And routine use of dopamine is avoided unless highly specific bradycardia is there in the patient. Finally, the de-escalation is very important. Fluids, where active fluid removal, post-resuscitation, actively remove fluids to prevent tissue edema. Antibiotics narrowing the spectrum, de-escalate when culture's susceptibilities return, and use procalcitonin plus clinical evaluation to stop antibiotics when optimal duration is unclear. Shorter courses are preferred over the longer courses for adequate source control. So These are the 5 things we need to, I will ask all of you to see. Recognition is the intervention. Vitals, mentation, perfusion, and source at the door. Screen with the scores, news 2, SIRS, and not QSOFA alone. And always refer to Gestalt. Lactate values. Do not resuscitate to a number. Balanced crystalloids and reassessment. Start peripheral norepinephrine and for early mean arterial pressure of more than equal to 65. And antibiotics within 1 hour of shock. Brief workup can be done up to 3 hours if no shock is present, and always seek source control. So we understood that sepsis survival begins with recognition, not recognition and only not antibiotics. So now I would like to ask my friend.
I will come with that. Thank you, Rajat. You have nicely presented the initial resuscitation part. But the thing is that not every case that comes to our emergency department is the same. Suppose, Deepak sir, to a simple suggestion, means to advise for that. Sir, suppose a patient coming to the emergency with greater than 48 hours of oliguria followed by anuria. And the patient is having abdominal distension with it. So, IVC, you cannot predict the IVC collapsibility in case of abdominal distension. And the patient is having persistent metabolic acidosis with it, and there is hyperkalemia. So what will be your initial part of resuscitation? Will it be fluid, or will it be a CRRT or renal replacement therapy? Sir, your opinion regarding that?
Yeah, in this scenario, generally the case you are putting forward is in a case of severe sepsis with MODS, especially the acute kidney injury with oliguria, and with metabolic acidosis, hyperkalemia, and most likely fluid overload also. In this perspective, you have to customize your, because these are basically the standard protocol for the normal patients in a general populations. When the patient's having the advanced organ failure, that's in form AKI, oliguric AKI, you have to be customized. This protocol will not fit in that, in the proper assessment or management of the case. In that scenario, the fluid is out. There is you have to be the more focus on that, how this potassium and this metabolic acidosis, because you can't give soda bicar in this scenario. It will further deteriorate your case. Then certainly you can use, depending upon the blood pressures, diuretics, high volume diuretics, high dosage diuretics, and you can put a central venous pressure, see the status. Because of abdominal distension, as in this particular case, your IVC assessment will be falsely. You are not able to, you can't see the IVC in that scenario. Little bit fluid if possible if the CVP pressure is somewhere around less than 10 or what. But definitely you have to urgently call your nephrologist team and to shift the patient in ICU setup earliest possible to start with SLADE or depending upon the hemodynamics or the CRT kind of thing. So this fluid assessment all vary with which category of patient you are catering with actually. So yes, this protocol will not fit in this particular, Dr. Arithro put up this case. Just it is not you can give fluid to every patient.
Thank you, sir, for your views. Sir, I will ask Pradhan sir for his views regarding the culture samples that need to be taken in the case of probable sepsis, based on your scores like your QSOFA or SIRS, whichever you take in the emergency for triaging a sepsis patient. So samples and how those should be taken, and how many samples they should be taken for blood culture, or how to take those. Sir, if you can give your views.
First, you need to identify which are the likely sources of sepsis. If urinary tract is the likelihood of source of sepsis, then urine culture has to be sent. Additionally, you will have to send blood culture for correlation. Though correlation is not always 100%, but if you get any correlation, then it increases your specificity. So if you are able to identify the source, then first is take culture from the source, intra-abdominal, urinary tract, or is it respiratory. You need to identify, give that specific source sample properly collected, then additionally you can send blood culture. If you are unable to identify the source, then obviously you can send blood culture. Then if you are not able to identify the source, then you have to send more set of blood cultures, because and blood culture you have to send more number of samples, because in sepsis the number of organism in blood is very low. The general guideline says you have to send at least 80 ml of blood. From 80 ml to 200 ml is the recommended volume of sampling of blood culture. So each blood culture bottle will held around 8 to 10 ml. So accordingly you can calculate, but at least I would recommend 4 number of blood culture. Though literature says 80 ml is the minimum, so that will become 8 number of blood culture. But I will recommend at least 4, because if, for example, if a commensal comes positive, for example, coagulation negative staph, you will require at least 3 number of samples to be positive with the same organism. So it will be easier for you to identify a commensal as a pathogen if you are able to send more than 3. So at least 4 blood culture has to be sent from any patient if you are unable to identify the source. Even if you are able to identify the source, then also you can send, but if you are unable to identify the source, at least 4 set of blood cultures. Has to be collected properly with proper aseptic manner. That's all. Means volume has to be adequate. Means at least 8 ml of blood per blood culture bottle, and at least 4 set.
Thank you, sir, for your views.
From the same.
Tito is asking, will the sample will be taken from the same site, or we will
preferably from different site, but there is no recommendation on the site itself.
Is the central vein through central vein should be taken, or peripherally we can take?
Peripherally is better. But if you are unable to take from periphery, then you can take from central line, provided you are not giving any antibiotics in the same line. And if you are giving fluids in the same line, then you have to take out that fluid from the central line. Means discard that first 5 to 10 ml of that fluid, then you can take the blood culture. Preferably from peripheral. You can send from the same site, but again, I'll recommend multiple sites, because it will increase the chances of recovery.
Thank you, sir. Thank you, Rajan, for your knowledgeable presentation. Now I will request Dr. Atri Kumar Sinha for views. Beyond the bundle, hemodynamic optimization and organ support. Be quick and precise. Huh?
So it's time to take the baton from my good friend Rajat and take you all on a ride into our department. Myself, Dr. Atri Kumar Sinha, and there's my friend come co-PGT, Dr. Mushaid Karim, and we are the general medicine residents. So good afternoon, everyone. I know I'm a post-lunch speaker. I also know that the emergency guys just hit you with lots of facts, and your parasympathetic systems might be working overtime just to digest all that meal, and your systemic vascular resistance might be falling as we speak. So before even starting with the slides, can I ask you all to do something very simple for me? Can we all raise our thumbs, please? Yeah? Now with your other hand, I want to place the capillary of the nail beds until it turns white. Yeah? Now just release the pressure and count the number of seconds it takes for the pink to return back. Go on. So if that took more than 3 seconds, I'm sorry, but you are possibly clinically hypoperfused. And I need you to sit up straight and take a deep breath. This is what I will be presenting today. What happens once the golden hour ends. Let's see how we keep the patient alive beyond the golden hour. I want you to take a look at the whole timeline given here. The first block is what we are all trained to do reflexively. R0 to 1, recognize and treat. The ER screens the patient, draws the culture, sends the lactate levels, and hangs that very crucial first bag of antibiotics. The R1 bundle just gets the clock started. Then we move into hours 1 to 3, resuscitation. We are pushing those initial fluids in and getting the NORAD going to restore the MAP. But I want to draw your attention to the right half of the skin. From hours 3 to 6 and beyond 6 hours. When we get that handoff in the medicine world or the ICU, this is generally where we take over. This is the optimization and de-escalation phases. This is where we have to figure out whether the patient actually needs more fluids, need to titrate the pressures, and eventually save the kidneys and draw all that fluid out. I want you to also take a look at the bottom box, because this is the thesis of my entire talk today. Antibiotics stop the infection, but hemodynamic optimization and organ support decide whether the patient survives the shock. The golden hour of medicine is very popular, but it truly extends well past the first dose of antibiotics. Sepsis is not just a low blood pressure problem. If it were, we'd just force the pressures and call it a day. It's actually a three-front war. First up, vasoplasia. The body just dumps the nitric oxide, the venous system pulls, and your vasopressin stores just pack up and leave. Second, capillary leak. The endothelium is injured. We can pour liters and liters of fluid into this patient, but it all leaks out into the interstitium. The patient may be drowning in pulmonary edema, but interstitially, bone dry. And finally, septic cardiomyopathy. This is the aspect we often ignore the most until we restore all of that afterload. Because that's when the left ventricle realizes it has to do all the hard work. Septic shock is defined as vasopressor requirement to maintain a MAP of more than equals to 65 mmHg plus lactate of more than 2 millimoles per liter despite adequate fluids. The end point here actually is microcirculatory failure. A normal MAP can absolutely coexist with dead anaerobic tissue. That's why we chase perfusion, not just pressure. So what's the target, you ask me? 65 mmHg has been etched into our minds by now. But the 2026 guidelines ask for a bit more nuance. For ages above 65, a permissive target of 60 to 65 mmHg is suggested over higher targets. But perfusion is just the floor. Pressure is just the floor. Perfusion is the real goal. How do we measure that, you ask? Lactate is great if it's falling by more than 10% every 2 hours. But just as my good friend Rajat here explained earlier, the lactate values can really fox us sometimes with his hepatic clearance issues. And just like that, we are chasing a number which has nothing to do with perfusion anymore. Remember, that's why I made you press your thumbnails earlier. Capillary refill time. The Andromeda shock trial tells us that this single free bedside 3-second test can guide resuscitation just as well, if not better than serial lactate values. Combine that with urine output and mentation, and suddenly we have got a free real-time monitor of organ perfusion in front of us. Now, this is probably the most sobering statistic of the day. Only about 50% of hemodynamically unstable patients are actually fluid responsive. So giving fluids to the wrong 50% is actively harming them. We are pushing them off the flat part of the Starling curve straight into pulmonary edema. So while measuring if a heart can take any more fluids, using static parameters like CVP is like taking an informed estimate at best. So we test, not guess. How do we steer, you ask me? We look at the static numbers historically, like central venous pressure or just eyeballing the JVP, and that still has a role today, but only in resource-poor settings. In modern medicine, we have scope to do so much better. So we use dynamic parameters, like passive leg raise test, which instantly gives the patient a 300 ml bolus without any risk of fluid overload. Or a fluid bolus challenge, where we do the same, but infusing the fluid externally. Or a stroke volume variation for fully ventilated patients. Or if you ask me, my personal favorite down in the ER here at Mission, POCUS. IVC and LVOT VTI actually give us a dynamic answer to a dynamic problem. We can't just trust those static numbers, or neither can we trust those physical examinations in isolation when deciding to give more fluids. So we test, measure the response, and then react. When we do choose to give fluids, the 2026 guidelines are absolutely clear. Balanced crystalloids are king. That normal saline can be anything but normal. The fluid we trust with our lives might be giving our patients hyperchloremic acidosis, and before we know, the patient may end up into renal replacement therapy. That Ringal lactate or plasma light actually respects the body's pH and chloride balances much more. So let's keep that NS aside for the traumatic brain injury patients or the hypochloremic alkalosis patients. And as for a sepsis patient in shock, let's keep it balanced. This brings us to a major paradigm shift. We now recognize that fluid is a drug, and just like any other drug, we need to know when to stop it and when to reverse it. We know of the ROSE concept, the resuscitation, optimization, stabilization, and evacuation plan. The fluids that helped us fill the tank on day 1 might be the same fluids that are drowning your kidneys and lungs on day 3. So we need to actively pull all that fluid out using diuretics or even ultrafiltration when required, because positive cumulative balance is an independent predictor of death. If you look at the boxes carefully, you will notice a pattern. Resuscitation and optimization runs from minutes through hours, while stabilization and evacuation takes days on end. So any mistake or overcorrection in the resuscitation and optimization plan will take days for us to stabilize. The key point here is trigger to de-resuscitate, where we target to even negative balance once the shock has resolved. Previously, we used to wait out for the fluid boluses before starting pressors. Not anymore. We start NORAD early, and we start it peripherally if we have to. Restoring perfusion pressure can't wait for a central line. And if the NORAD requirements are climbing above 0.3, we don't just keep cranking up the dial, we add vasopressin, and that too early. As for septic cardiomyopathy patients with low output, we switch over to dobutamine or epinephrine based on the rhythm. 2 ideas. First, the genuinely new rhythm-based rule for septic cardiomyopathy. Tachyarrhythmic, norepinephrine, epinephrine, to avoid adding rate. Bradyarrhythmic, epinephrine for its beta-1 chronotropy. As for normal sinus patient, either works fine. Second, ionotropes go on top of pressors for eco-proven low cardiac output states. Add dobutamine to norepinephrine or epinephrine alone. The bottom block light here, that's where what I call the resist your temptation row. Beta blockers are now a suggest against, levosimendan is out, methylene blue and midodrine are still not fixed, but are situational only. Steroids in septic shock is a tale as old as time. The 2026 consensus, hydrocortisone is a pressure-sparing adjunct to catecholamine refractory shock. It's not a magic mortality bullet. Yeah, it gets the patients off pressors about 30% faster, but watch out for that hyperglycemia and hypernatremia. So we start it when the NORAD requirements are climbing and stop it once the shock resolves. Although most trials are done on the continuous infusion part of hydrocortisone, real-world studies found out that the intermittent dosing works just as fine. So the typical dose we use is 200 milligrams of hydrocortisone every 24 hours. Now, as we move into the maintenance phase, we have to monitor perfusion. The problem is there's no single perfect metric. Lactate is our classical go-to, but isn't always reliable, just like Rajat told us. On the flip side, capillary refill time is great, rapidly responsive, but subjective. We track trajectory by combining all of these imperfect signals. We look at the serial lactate values, we look at the capillary refill time, the hourly urine output, and the patient's mentation. If 3 out of 4 are improving, we are possibly moving on the right track. Why are we so obsessed with just tracking the perfusion metrics, you will ask me next. This is the slide why. Because sepsis still is the undisputed heavyweight champion of acute kidney injury in ICU. The kidneys are incredibly greedy when it comes to blood flow and are the first organs to take a hit every time the microcirculation goes for a toss, because they take up about 1/4 of our cardiac output. So saving the kidneys is of paramount importance, and we often employ the renoprotective bundle. Saving the kidneys doesn't always mean blindly throwing fluids at them. It means maintaining that perfusion pressure early and maintaining it properly and avoiding every extra liter of unnecessary fluids that we can do. As for bicarbonate, we keep it reserved for pH of less than 7.2 with advanced AKI only. If there's one trap we often fall onto in a highly monitored ICU environment, it's actually looking at the monitor more than we are looking at the patients. A mean arterial pressure of 65 is the target. Sure, but if the monitor reads 65, but the patient's knees are malted, he hasn't made a drop of urine in the last 4 hours, or can't tell you which year it is, that MAP is a lie. Conversely, when a monitor reads 60, but the patient is comfortably speaking with you and is maintaining a good urine output, forcing pressures on him just to make the monitor read 65 may be actually doing more harm than good. So a target is okay, but that shouldn't be the only factor. No single factor overrules the holistic patient lying in front of you. Lactate is still our workhorse for resuscitation and prognosis. Procalcitonin's real role is in stewardship, where it guides antibiotic de-escalation or stoppage, but not in diagnosis. SOFA is a risk stratification score, and QSOFA is a weak screening tool that has already fallen out of favor in the 2026 guideline. As for a peep into the future, Presepsin, MR-Pro-ADM, transcriptoning endotypes may finally be able to provide us with a clue as to which patients are actually steroid responsive. So bringing it all home to our daily practice, what has actually changed for us seeing the patients at 3 a.m. in the medicine wards? First of all, we stop writing continue IV fluids and walking away. We realize that fluid is a drug and one with a very narrow therapeutic index. We stop writing that normal saline as a default. Second, we understand that giving pressors is of paramount importance if required peripherally. So we push for that early aggressive noradrenaline, get those perfusion pressures high, and once we are high enough, we try to find out an axis. This is all about the marriage of the classical clinical symptoms and methods we learned in Hutchinson's for years, and then combining it with the modern technologies and leading to a better care and better resuscitation. And we don't just resuscitate, we optimize, we stabilize, and then de-resuscitate once required. So this brings us to what I consider the ultimate internal conflict we face every single day during rounds. Look at the title of this slide: clinical examination versus numbers. If you walk into any modern ICU, it's incredibly easy to feel overwhelmed and feel like we are seeing less of the patients and treating more of those fancy monitors. On one hand, we have got Hutchinson's, who continuously reminds us that clinical examination is of paramount importance. If a patient's skin is pale, the patient is not making any urine, the mentation is altered, the patient is in shock, end of story. But on the other hand, we have got the modern critical care physics reminding us that we can't just eyeball a fluid responsiveness. We can't just rely on static parameters like jugular venous pressure to give us a good feedback as to guide fluid resuscitation. So who wins the battle? The answer is we stop treating them like opponents. The both factors are important. The problem arises when we get tunnel vision into one of those extremes. So for a medicine resident, we don't really have the luxury of ignoring either. We have to take both and treat the patient as well as we can. To wrap this up, the bundle is just the starting gun. We predict, then give. We test fluid responsiveness dynamically and drone down our patients, please. We restore flow early. We start NORAD early, add vasopressin when escalating, and use steroids to spare our pressors. And finally, we chase perfusion, those lactate trends, CRT, urine, mentation, and protect the kidneys by preventing overload. With that, I would like to call upon stage my good friend Abesh from pulmonology to take over. Thank you.
Thank you, Atri. Wonderful presentation. I think I have to relearn the art of presentation from you.
That's really a compliment. I will always remember, sir.
So, two things which I can, at least one thing which I can get, that there is no perfect fluid.
Yeah, sir.
There is no perfect fluid.
There is nothing
And there is
such.
no perfect formula how much to give.
No, not really.
Not yet, no? So, sir, any comments from the panelists? Okay, better not to waste the time. I will call upon the stage Dr. Abesh Bandapad to have his views.
Good evening, everyone. My name is Dr. Abesh Bandopadhyay, a first-year DNB pulmonary medicine resident at the Mission Hospital, Durgapur. And today, I will carry the torch from my very dear friend, Dr. Otri, to continue this sepsis journey. Now, as being a pulmonary medicine resident, I have been bestowed upon the responsibility to discuss the relationship between sepsis and lung. So the topic of my today's presentation will be when sepsis hits the lung, from pneumonia to ARDS. So to begin with, we must remember that sepsis and lung, they have a bidirectional relationship between them. Lung infection or pneumonia, both community acquired and hospital acquired, is often the entry point for systemic sepsis, whereas sepsis itself worsens the lung permeability and can precipitate respiratory failure. So, in case of pneumonia patients, early source identification with chest imaging, culture of the respiratory samples, and whenever available, multiplex PCR must be sent before starting the first dose of the antibiotic. Coming to the pathophysiology. So, whenever a microorganism enters into the lung, the alveolar macrophages first recognizes the pathogens via toll-like receptors and pattern recognition receptors. Then, it releases a cascade of inflammatory mediators like TNF-alpha, interleukins, and interferon gamma, which further causes complement activation. Now, these inflammatory mediators further activate the neutrophils, which then migrate into the alveoli, producing reactive oxygen species, proteases, and neutrophilic extracellular traps, which leads to alveolar tissue injury, leading to acute lung injury and ARDS. So now, whenever the inflammatory mediators, after causing the lung injury, they spill into circulation, it leads to cytokine storm, which develops different systemic effects. So what are the systemic effects? They are endothelial dysfunction, followed by vasodilation and capillary leak, which leads to redistributive hypotension, and coagulation activation, which presents as microvascular thrombosis. So now these inflammatory mediators, they cause a cascade of consequences like protein-rich alveolar edema, reduced surfactant, atelectasis of the lung, and severe ventilation perfusion mismatch, which lead to breakdown of the alveolar capillary barrier and hypoxemia. Now, let's come to a clinical case to discuss the effect of sepsis into the lung. So supposedly, a 64-year-old male, known diabetic on OHA and hypertensive on tablet telmisartan, presented with fever, cough with yellowish expectoration, shortness of breath for last 4 days. On examination, his blood pressure is 110/58, heart rate of 122 beats per minute. He is having tachycardia, hypoxemia with a SpO2 level of 88%, and he is febrile. Investigations are done, which reveals a total leukocyte count of 18,000 with a 92% of neutrophilic predominance, a CRP level of 302, procalcitonin of 15, chest X-ray showing left-sided lower zone consolidation, and sputum multiplex PCR showing growth of Streptococcus pneumoniae. So the patient is being admitted in the ward. He is being managed with IV fluids, IV antibiotic, and supportive therapy. On the 4th day of admission, his symptoms suddenly worsens. He requires oxygen at almost 8 to 10 liters per minute with high flow mask, and ABG shows type 1 respiratory failure with a PO2 of 56. He is further shifted to the ICU and put on non-invasive ventilation with an FiO2 of 60%. A chest imaging or chest X-ray is done, and it shows bilateral diffuse infiltrations. So with these sort of a clinical presentation, with sudden worsening of the symptoms, high FiO2 requirement, bilateral opacity in the chest X-ray, and ABG showing type 1 respiratory failure, the first diagnosis that should come to our mind is ARDS, or acute respiratory distress syndrome. So in 2026, according to the systemic review and meta-analysis, in almost 34% of the severe sepsis patients, they develop ARDS. And that's why diagnosing or identifying ARDS at an early stage is key to treating severe sepsis patients. Now, what is ARDS? According to the AECC definition 1994, there were 4 parameters. First, it should be of acute onset. Second, there should be bilateral infiltration on chest X-ray. Third, the edema should be of non-cardiogenic origin with a pulmonary artery wedge pressure of less than 18 millimeter of mercury, and PaO2 by FiO2 ratio of less than 200 millimeter. In the year 2012, the Berlin definition actually modified the criteria a bit. So it told that the timing should be within 1 week of a known clinical insult like sepsis or pneumonia. The imaging should show bilateral opacities on chest X-ray, not fully explained by effusion, collapse, or nodules. The origin of edema should be non-cardiogenic, and the oxygenation severity actually graded ARDS into 3 grades. First, mild with a PF ratio of 200 to 300, moderate with a PF ratio of 100 to 200, and severe with a PF ratio of less than 100. So, why ARDS is such a dreaded complication in case of sepsis patients? It's because the choice and titration of an oxygen delivery system in the very first hours often determines whether a patient of ARDS stabilizes on non-invasive support or progresses to respiratory fatigue and requires the need for mechanical ventilation. So in ARDS patients, on one side, under oxygenation risks end organ hypoxic injury. Secondly, over-reliance on non-invasive support risks patient self-inflicted lung injury or PCILI, whereas delayed intubation after long-time non-invasive failure is often associated with worse outcomes. So the key is to strike a balance, to escalate fast enough to avoid PCILI without intubating so early that it exposes the patient to unnecessary invasive ventilation risk. Frequent monitoring is the key. So why ARDS is different than other lung pathologies, and why the hypoxemia caused by ARDS is generally not treated by simple oxygen? The reason lies behind the pathophysiology. First, because of the intrapulmonary shunting. So what happens in case of ARDS is that because of systemic inflammatory response syndrome, the alveoli are filled with edema fluid. So
the places which are filled with this fluid, they remain perfused. The blood circulation to those places is maintained, but they remain unventilated. So blood bypasses the gas exchange. Second, ventilation perfusion mismatch. In ARDS, there is heterogeneous lung involvement, which creates units with low ventilation relative to perfusion. And last but not the least, there is increased work of breathing. As I already said earlier, that there is destruction of the and leading to reduced compliance and hypoxic drive, which raises the patient's respiratory rate and effort. High inspiratory flow is demanded to relieve the patient. So the practical takeaway being, because of the shunt physiology and ventilation perfusion mismatch, there is a ceiling effect of FiO2 alone. So devices that also unload the work of breathing of the patient and recruits the alveoli, they are much preferred. In case of mild cases of ARDS, we may give a trial of low-flow oxygen delivery devices, but in case of moderate to severe cases, they are of practically no use. So in the high-flow oxygen delivery devices, the device that is preferred most often is high-flow nasal cannula. The reason being, the patient is already hypoxemic. He is hyperventilating, he is having respiratory distress, he is using his accessory muscles, and over that, often using an NIV mask creates a kind of discomfort for the patient and creates a sensation of claustrophobia. HFNC relieves that. So a trial done in the year 2015, Florally trial, showed that acute hypoxemic respiratory failure, HFNC, reduced the 90-day mortality compared with standard oxygen with NIV. So why NIV is preferred? It's because of the high flow to up to 60 liters per minute. It washes out the carbon dioxide from the nasopharynx, causing a dead space washout. It gives a low PEEP of 2 to 5 centimeters of water, and it provides heated, humidified gas. Now, NIV or CPAP, continuous positive airway pressure, can often improve the oxygenation by delivering PEEP and unloading the respiratory muscles. But in ARDS, its role is narrower and more cautious. A study, lung-safe study, done in the year 2016 showed that NIV failure occurred in almost 30 to 50% of ARDS patients started on it. So, in case of moderate to severe ARDS, we may use NIV, but while giving ventilatory support by NIV, we should be very cautious because there are some red flags. First, being moderate to severe ARDS with a PF ratio of less than 150. Second, poor mask tolerance. Third, large tidal volumes given on NIV. And fourth, hemodynamic instability. Next is a concept that is very often used in case of ARDS is proning. It can be done in the earlier stages of mild cases as awake self-proning and in the moderate to severe cases as prone ventilation. So the mechanism behind that is prone positioning the patient from supination actually improves the ventilation perfusion matching by recruiting the dorsal lung units and reducing the compressive atelectasis. But self-proning a patient when they are on NIV or any other support must be checked with other practical points like combining it with HFNC or NIV. The aim for self-proning should be to maintain over 8 hours. Repositioning should be done for feeding, hemodynamic checks or discomfort, and it should be stopped if there is hemodynamic instability, arrhythmia, worsening distress. So during the COVID time, a study done by Roca et al. Gave us an index, the ROX index, which actually showed us the utilization of NIV or HFNC and gave us the indication for further escalation for intubation. So the ROX index is SpO2 by FiO2 divided by respiratory rate. It should be measured after initiating a patient on HFNC at 2nd, 6th, and 12th hour. So a ROX index of more than 4.88 shows low risk of HFNC failure and the patient can be continued and on HFNC. A ROX of 3.85 to 4.88 is indeterminate, and the patient is needed to be reassessed every 1 to 2 hours. And a ROX of less than 3.85 shows high risk of HFNC failure, and we must prepare the patient for intubation. But as we all discussed, intubating an ARDS patient is a very critical decision, because after that, maintaining the ventilation in an ARDS patient is extremely critical. So beyond the number of a ROX index, we should always assess the whole patient. First, we should check the respiratory pattern for accessory muscle use, paradoxical motion. We should check the sensorium, the hemodynamics, the speech of the patient. We should do serial EBG to look for rising PaCO2 levels and not just oxygenation. And we should reassess at every 1 to 2 hours. So coming to the absolute indications of intubation in case of an ARDS patient: first, cardiac or respiratory arrest; second, inability to protect the airway; third, copious secretions or airway obstruction which the patient cannot clear; fourth, refractory hypoxemia despite giving maximal NIV support; fifth, hemodynamic instability or shock; and sixth, severe worsening respiratory acidosis. Coming to the relative indications which indicate impending failure: ROX index of less than 3.85, tachypnea, poor tolerance on NIV, failure of a trial of awake proning, no improvement of PF ratio after 1 to 2 hours, accessory muscle use, rising FiO2 requirement, and last but not the least, the clinician's choice. So now the patient is intubated and he is mechanically ventilated. Now the treatment of ARDS follows 4 main pillars. First, lung protective ventilation; second, adequate PEEP; third, prone ventilation; and fourth, ECMO. So this term, lung protective ventilation or low volume high PEEP ventilation, is often used in managing the ARDS patients on ventilation. But what does it actually mean, and what was the source of it? So the ARDS NET study done in the year 2000 showed that there is a 22% relative reduction in mortality with patients who were treated with a tidal volume of 6 ml per kg over patients who were treated with 12 ml per kg. So that ARDS NET study actually gave us the idea of an ideal ventilation settings in case of ARDS patients. The tidal volume should be started with 8 ml per kg of predictive body weight reduced to 6 ml and should be maintained within the range of 4 to 8 ml per kg to maintain a plateau pressure of less than 30 centimeter of water. The respiratory rate should be within 35 per minute, and the arterial pH goal should be 7.3 to 7.45 to allow permissive hypercapnia. Now, along with the low tidal volume,
we are already running short of time, kindly.
Okay. So, along with the low tidal volume, PEEP is also very important for ARDS ventilation, because too little of PEEP actually causes the alveoli to collapse at the end of the expiration and causes the reopening in the inspiration, causing atelic trauma, whereas too much of PEEP causes over-distension of the already open compliant units, leading to barotrauma and volute trauma. So while ventilating an ARDS patient, the goal should be to maintain the lowest PEEP that provides adequate oxygenation and lung recruitment without compromising hemodynamics or causing over-distension. Prone positioning, as I already mentioned, in PROSERVE trial, it was showed that prone ventilation of more than 16 hours per day showed reduction in the 28-day mortality to 23.6% in comparison to 41%. Now, if the patient is in severe hypoxemia with a PF ratio of 150 and with adequate ventilation and PEEP, he is not maintaining the FiO2 after 36 hours, we can go for prone ventilation. And for the rescue therapies, there can be neuromuscular blockade, which helps to improve ventilator synchrony, inhaled pulmonary vasodilators, nitric oxide or prostacyclins, which causes pulmonary vasodilation and improves the ventilation perfusion mismatch, multiple recruitment maneuvers, and ECMO. Thank you.
Thank you, Abesh. Wonderful slides from you. Now, without wasting any time, I will ask Adil to prepare his slides. In the meantime, as per Abesh, so lung is the battlefield of sepsis. So we have Das sir as the ringmaster of the lungs. So we should hear some views from the master itself. Any views, sir, extra? None. Okay, Adil, continue with your presentation.
Only covered, and it is all of you are doing. So by doing, you will learn how to ventilate.
Good evening, everyone. My name is Dr. Muhammad Adil. I am presenting you the importance of source control in sepsis management. Sepsis care stands on 4 pillars, not 3. Source control is the 4th pillar.
In the meantime, I'll say all the DNB students are covered very well. Right from the emergency to medicines and pulmonology, they have excellently you have prepared slides.
A drug cannot reach what a knife must remove. Why the focus resists antibiotics? Because of poor penetration, huge bacterial burden, biofilm and foreign body, and ongoing contamination. Source control removes the reservoir. We can do drainage, debridement, and device removal. 4 mechanical goals. First, we start with the least invasive, like drainage. Then we can do debridement, device removal, and definitive control like resection, diversion, and repair of the disease source. 7 foci where the surgeon owns the source. Hollow viscous perforation, complicated appendicitis like perforation, abscess, acute cholangitis, diabetic foot infection, necrotizing soft tissue infection like necrotizing fasciitis, empyema and infected collections, intra-abdominal abscess. Free spillage becomes shock in hours. Peptic gastric or small bowel or colonic perforation spills gastrointestinal contents into the peritoneum. Generalized peritonitis and bacteremia drive distributive shock fast. Source control. We close or resect the perforation, diversion stoma when repair is unsafe, and damage control laparotomy if the patient is unstable. In case of acute cholangitis, decompression is the definitive antibiotic. An obstructed duct because of stone, stricture or tumor turns bile into a closed infected space under pressure. Bacteria are forced straight into the bloodstream. Antibiotics alone cannot decompress a blocked system. So source control is biliary drainage. ERCP is the first line. Percutaneous drainage or surgery if ERCP fails or anatomy forbids. The truest surgical emergency is necrotizing soft tissue infection. Pain out of proportion to exam, rapid spread, systemic toxicity, tense edema, crepitus, bulla or dusky skin. Skin changes are late. The fascia is dead beneath near normal skin. So we do early radical debridement of all necrotic tissue till the bleeding margins are visible. Planned relook at 24 to 48 hours. Repeat until clean. Amputation if the limb is non-viable. Broad antibiotics are also given that are adjuncts, not substitutes. In intra-abdominal abscess or collections, we drain what we can reach and operate what we can't reach. Like image-based percutaneous drainage, first line for accessible unipocelocular collections, diagnostic and therapeutic we send the fluid for culture, surgical drainage, and we address the source. Match the operation to the presentation in cases of complicated appendicitis, like perforation, and if there is perforation and peritonitis, we do prompt appendicectomy with peritoneal lavage. In cases of when the abscess is contained or a phlegmon is formed, we give antibiotics and image-guided drainage if necessary and consider interval appendicectomy. In case of generalized sepsis, we resuscitate and then we take the patient towards the OT. In diabetic foot infection, the neuropathy hides the pain, vasculopathy starves the tissues, and immune dysfunction lets infection race through deep plantar spaces. The surface can look trivial, while a deep abscess, wet gangrene, or necrotizing infection tracks along tendons. So we do urgent incision and drainage or debridement of the deep collections. In case of wet gangrene or systemic sepsis, emergent debridement or amputation if necessary. Access perfusion early. In case of empyema and infected collections, like in case of parapneumonic effusion, if there is exudative collection, we give a chest drain. In case of fibropurulent, we give a drain and then an intrapleural TPA. In organizing collection, VATS is needed. So the concept, the source control are first the recognition clock, then the antibiotic clock, and then the source control clock. All three clocks at presentation and they run together. The SSC 2026 guideline tells that achieve the source control as soon as it is medically and logistically feasible. In practice, within 6 to 12 hours for most sources and immediately for the time critical ones. These are the evidences that states that in case of GI perforation plus septic shock, a 60-day survival falls steeply with each hour to source control within the first 6 hours. Like in severe sepsis, a cohort was conducted. Source control achieved more than 6 hours. Independently was associated with higher mortality. The red flags that override the optimization first, like necrotizing soft tissue infection, ischemic or necrotic bowel, perforation with peritonitis plus shock, obstructed and infected systems like cholangitis, grade 3, and pyelonephritis. There's still a debate like resuscitate first or we control the source first. But in case of these red flags, we have to control the source first. So the take-home message is antibiotics do buy us some time, but source control stops the clock. These are the key references from where I have taken this presentation.
Thank you, Adil, for the presentation. I now want to ask Dr. Jacinta, do you want to add something? Okay. So, thank you. You can go. Anything from the panelists? Okay. So now we have learned all about the sepsis. Many of things we have learned. And so what weapons we have in our hand now? Sir, anything you want to add? So what weapons we have in our hand? So fluids, vasopressors. First is definitely the recognizing the sepsis. Organ support in form of ventilation, CRRT or dialysis, and antibiotics. So please have some energy, and I will be requesting Dr. Arkendu for the plenary session on antibiotics.
Good evening, everyone. It's already too late and people are tired, so though this is an extensive topic, I'll try to cut it short. To start off, the topic that was provided to me was the last antibiotic standing, can emergency department outsmart resistance? So I will start off with an emergency department dilemma. So first we have to understand that to make a decision, an emergency physician has 10 minutes. But the culture needs 48 hours. So I'll start off with an imaginary case. I'll start off with an imaginary case where it's a very frequent case that we encounter in our emergency. So we have a 68-year-old woman with fever, altered sensorium, hypotension, with an history of pyuria, obstructed urinary tract, and degestant in situ. She was hospitalized 3 weeks previously and received meropenem. Previous urine culture showed carbapenem-resistant Klebsiella with a creatinine of 2.2. So, what would you give in the first hour, and what information will change that decision? Options: maybe meropenem, maybe colistin, maybe ceftazidime avibactam. So, what would be the consensus? Actually, we would need 3 more pieces of information to decide. So I will move on to the case in the end of the presentation. So what is the last antibiotic? It is not one drug. The last antibiotic standing might be a carbapenem in an ESBL infection. If the resistance for carbapenem-resistant Enterobacteriaceae is KPC or OXA48, then maybe ceftazidime avibactam will work. If it is a metallobeta-lactamase producer, actually co-producer along with KPC or OXA48, then aztreonam along with avibactam activity would be of choice. For highly resistant gram-negative organisms, cefiderocol is an important option which is still not available with us, but we have an upcoming cefepime-zirabactam which will probably be available with us in a few months. For carbapenem-resistant Acinetobacter, last standing antibiotic is high-dose sulbactam-based therapy. And whenever safer active options are unavailable, polymyxins are what we revert back to. So a reserve antibiotic is not the strongest antibiotic. It is basically the narrowest reliably active option for that particular pathogen, the patient, and the site. So what is the emergency department paradox? The thing that troubles the emergency physicians is too late antibiotic kills, however, selecting too broad antibiotics selects resistant organisms. So the immediate threat is delayed active therapy, inadequate spectrum of the antibiotic chosen, inadequate dosage, and maybe missed source control. While the downstream threat is unnecessary use of reserve antibiotics, antibiotic-mediated toxicity, Clostriditis difficile infection, superinfections, and the most important and the pressing need of the issue of the hour is selection and transmission of resistance. So what we need to understand is first does not have to be blind. The current 2026 SSC differentiates patients by probability and severity. So if the patient is having septic shock or a probable or definitive sepsis, then antimicrobials must be started immediately, ideally within 1 hour. If it is possible sepsis without any shock, then the evaluation should be rapid and time limited, but we get a bit of more time to start antibiotics. It has to be started within 3 hours. And if there is a low probability of infection without shock, so antibiotics may be deferred with close monitoring. So moving over to the steps that I had mentioned earlier. So first we need to know, is this bacterial sepsis? So we have to pause at that point, but we should not procrastinate because time is of essence. So the 3 emergency department questions are, is infection likely? Is organ dysfunction present? Or is shock present? So what are the common traps in emergency department? There are multiple mimics which may trigger reflex use of broad spectrum antibiotic therapy. There might be cardiogenic or hemorrhagic shock, pancreatitis, pulmonary embolism, drug fever, and so on. As already discussed extensively, we have to remember that lactate is a severity signal. It is not a prescription for meropenem. So moving over to step 2, we have to identify the resistant host. So the 5 P's are the MDR risk screen. First P is previous MDR colonization or infection. The second one is previous broad spectrum antibiotics, especially within the last 90 days. Any history of previous hospitalization, ICU or healthcare exposure. Plumbing, which is the most important probably. Any catheter in situ, any stent, drain, tracheostomy or vascular device in situ. And place. where the patient is located currently. So every unit has a specific ecology and a local antibiogram which that particular unit must be aware of. Other modifiers are residence in a long-term care, hemodialysis, immunosuppression, recurrent healthcare associated infections, and invasive procedure. Again, the checkpoint is healthcare exposure increases probability. It does not automatically justify use of every last line agent. And the most important step, step 3, we have to retrieve before we prescribe. The most useful rapid diagnostic may already exist with us. So a culture from the last month may be more useful in the first 10 minutes than a biomarker that is drawn today. So that can be retrieved from EMR, from previous microbiology reports, and that guides us to empiric decision. So what the emergency department should look in the first 10 minutes, if they have any previous cultures or susceptibility patterns, if they have any previous carbapenemase result available, any recent antibiotic exposure history, if the patient has any known MDR alerts or colonization, if there is a prior clinical response or failure to a particular antibiotic or drug, what is the current hepatic and renal function, and drug energy phenotype. Step 4, which doesn't apply to our particular case, but what we must remember is that we have to sample intelligently. So antibiotic runs on a clock, but that clock must not erase the diagnostic window. So before antibiotics, we have to collect 2 appropriately collected blood culture sets, at least urine culture whenever feasible. Depending on the localization, suspected localization of the infection, any good quality respiratory sample, any aspirator tissue rather than a superficial swab, drainage sample from infected collection, and in high-risk patient, rapid molecular testing. But again, we have to remember that this is to be done only if it does not cause any meaningful delay in antibiotic administration. What we need to avoid is routine cultures without a compatible syndrome, like sending urine culture for all patients without any localization. That is not justified. Again, sampling long-standing drainage bags, that will definitely yield a candida and bias our system. Treating colonization and treating asymptomatic bacteria except for established indications, and this is what I need to emphasize on because this is a problem every hospital faces these days. Step 5 is adequate but not maximal therapy. So empiric therapy in the emergency department is a probability decision and uses a simple equation: syndrome plus severity plus host plus prior microbiology and local antibiogram. So there are 3 lanes basically: green, amber, and red. Green is for stable patients with community onset disease and low MDR risk, where standard syndrome-based therapy is sufficient. Amber is severe infection plus healthcare or MDR risk. In these cases, we have to broaden our empiric antibiotics selectively using previous cultures, or whenever that is not available, using local ecology and antibiogram. And red is where we need to think and maybe act on a reflex tone. So where we have a shock with a strong evidence of specific resistant bacteria, we have to ensure immediate active coverage against that mechanism. So we need to understand the mechanism before the molecule. So if we have an ESBL enterobacterials with severe invasive infection, carbapenems are generally recommended for KPC or OXA48 like carbapenem resistant enterobacterials. We need to use a newer beta-lactamase inhibitor which is guided by susceptibility. For NDM or other MBL, if it is present alone, aztreonam alone is sufficient, but generally we have that as a co-producer with KPC or OXA48. So aztreonam plus avibactam activity is recommended. For DTR pseudomonas, we have to select for susceptibility because there is no tailor-made option for that. And we have to reserve polymyxin whenever safer active beta-lactams or aminoglycosides exist. For carbapenem resistant acinato, high-dose sulbactam containing combination therapy is the choice. And this high dose should be 9 to 12 gram per day, and underdosing does not really help our cause. As far as MRSA risk is concerned, we have to add an anti-MRSA therapy only when the clinical or risk evidence supports it. So what we need to understand is, we should not infer carbapenem's mechanism merely by meropenem resistance. We have our molecular techniques for resistance mechanism. We have our enzymatic ICT techniques for this resistance mechanism detection. So we must utilize that before deciding anything on a jerk reflex. And exact choices must always follow institutional antibiogram, susceptibility report, infection site, renal function, and current local formulary. Now, the first dose should always count. Correct drug with a wrong exposure is inadequate therapy. So giving a full loading dose in severe sepsis despite AKI in most situations is the dictum. We need to adjust the subsequent maintenance doses. The first dose is the most urgent and it should be given in full. And we have to consider augmented renal clearance whenever that is indicated. Again, prolonged or extended beta-lactam infusion is the recommendation, not the practice that we have of giving it in a shot. We have to consider obesity, extracorporeal therapies for antibiotics, particularly in the critical care setup. And again, the antibiotic should have penetration to the suspected site, like giving daptomycin for pulmonary infections or giving tigecycline for bloodstream infection does not really count. If we need to give that, there is specific doses recommendations for that particular antibiotic in that particular site. And the most important thing is the knee-jerk reflex of giving unnecessary double gram-negative coverage. Doesn't help in anything. Even the current neutropenia guidelines do not recommend empiric double gram-negative therapy. So AKI should, the take home from this slide is AKI should modify maintenance dosage and not produce an underdosed fast hour. So now the most important antibiotic of the all, source control. So we have to understand that sometimes the last antibiotic standing is not an antibiotic. For example, obstructive infected urinary tract, which have been extensively, these foci have been extensively discussed by a surgical resident. So what we need to understand from this is that escalating meropenem cannot drain pus, remove catheter, or relieve to an obstruction. So another important thing is the ED to ward antibiotic handshake. So every empiric prescription needs an exit plan. ED documentation should state what is the suspected source, how the cultures were obtained and what cultures were obtained, MDR risk factors and reason for reserve antibiotic use, the dosage and infusion plan, source control requirement, and mandatory antibiotic timeout at 48 to 72 hours. So at this 48 to 72 hours, we have to review and stop if infection is unlikely, narrow to the identified pathogen, remove any redundant coverage if it is there, convert to IV to oral whenever appropriate, and define duration at that point. And again, need to involve microbiology or infection control early for CRE, CRAB, DTR pseudomonas, or any diagnostic uncertainty. So moving back to the opening case, so what should be the decision-making process? It is a case of septic shock, so needs immediate active therapy. The likely source is urinary tract with obstruction, so urgent source control with a digestant. Maybe the digestant is not functioning, so that has to be assessed and restenting should be done. So as there was a previous CRE isolate documented, we have to retrieve susceptibility and carbapenemase data from that. Primary source is urine, so urine culture and blood cultures are to be taken, and based on the retrieved susceptibility or carbapenemase data, we have to start a mechanism appropriate therapy and give an optimized loading dose, and considering the AKI part, we have to renally adjust the maintenance doses and review at 48 to 72 hours when cultures become available. So yes, the ED can outsmart resistance, but only if speed is paired with memory, microbiology, and accountability. The 5 steps are to recognize true sepsis and its severity, to retrieve previous microbiology, sample before antibiotics whenever feasible, target the likely pathogen and mechanism, and reassess and de-escalate at 48 to 72 hours. Thank you.
what should be your choice of antibiotic in this case?
I would start with, I would like to get the susceptibility data. If it is, or at least the molecular data. If it is a KPC or OXA48 producer alone, then I will start with ceftazidime avibactam as you had said, sir. But if it is a co-producer with an MBL, I would have to go with avibactam astronome activity.
Okay, thank you.
Thanks, Arkandu. That's called a plenary session. So what we take home message from the entire presentation on sepsis. So first recognition, then resuscitation, then simultaneous organ support and detection of the source, then source control by means of surgical intervention or antibiotics. So this is our take-home message. So I will request the entire ED team to at least involve Arkandu in each and every sepsis case to implement a handshake which he has mentioned between ED and ICU. So that thing should be taken into account. Thank you, Arkandu. I will call upon the stage all our DNB residents, please, for the valedictory session. Arkandu, please. Dasar, please. Hey,
Requesting Dr. Taruk, Dr. S.K. Das sir, and Dr. Pradhan sir to give away the mementos to Dr. Deepak Kumar, Dr. Arkendu Basu, and our bright DNB residents. Dr. Tirtho Mukherjee, please do the honor.
Thank you, everyone.
Thank you, everyone. Thank you for giving the opportunity.
May we please have Dr. Jacinta Christiana and Dr. Anmol on stage for declaring the Best Paper Presentation Award.
A very good evening, everyone. Without any further ado, let's jump to the winner of the award paper. So the award goes to reducing length of stay in emergency department through implementation of Six Sigma in a tertiary care hospital by Dr. Erythro and Dr. Piali.
That brings us to the end of the academic sessions and the plenary session, and also brings us to the end of this program. But we would like to have Dr. Partho Pal here, our medical director, to kindly deliver the vote of thanks.
Before giving Dr. Parthopal sir the opportunity to give the vote of the thanks, no event is without end. Every event is an team effort. We were helped at each moment from the operation team, from our IT team, from our marketing team to make this event a success. I know there were many loopholes. Now at the end of the time, very few people are there who are listening to us. Still it takes a lot of hard work to make it success. And I want to thank especially our Master of Ceremony, Ms. Ishani Chakravarti. Madam, please come on the stage for a small token of appreciation. Parthwal sir, please. Tithoda, please come on the stage and felicitate Madam. Dr. John, please. Thank you, Madam, for being the light beacon and bearing us throughout the program. Now I will hand over to Dr. Parthopal sir for mentioning the vote of thanks.
So this is the end of the session. I thank all of you for your presence. And what more to say? Your participation had been really marvelous. So thank you all. Thank you. The session ends here.